Thank you.
You're welcome.
Did anybody hear of any colleagues who wouldn't be able to join us?
I don't believe Representative Madigan will be here until this afternoon.
Okay.
I was looking for the link as well, and I had to ask Karen for a new one. I have every date in the world, but I couldn't find today's date, so maybe people were, I don't know, looking for it as well.
Okay.
And I know that Representative Connor is not feeling very good, and he may or may not join in to listen, especially to the briefing with Dr. Shaw.
Okay, very good. Good morning, Representative Lemelin.
Yep. Karen.
Morning, Senator.
You're back in your usual digs. You were in a different place the last day or two.
Yesterday, I was actually out on Sebago Lake where my daughter is living. She had a problem with the heat, so I had to go out and help her.
Karen, could you send a link to Representative Zager, please?
Absolutely.
Representative Javner, did your daughter get her pipes thawed? Yes.
Yes, thankfully. The joys of home ownership.
Yes.
So for those of you just joining us, we're waiting for a couple of our colleagues to get squared away on access to this hearing. Good morning, Sam. How are you?
Good morning, I'm good. I wonder if perhaps we should resend the link to the whole committee, just in case there's anyone else who's missing it.
Okay.
Will do. I just sent it to a couple of others, so I will resend to everybody.
Thank you.
I do a lot of
did-
cutting and pasting as these appointments come across, and
Yeah.
I put an asterisk after the meeting title to mean that I've got my link. So I can tell by looking at the calendar.
Well, it is a little bit different because it's not a webinar. So I
Right.
think that's why it looked different in the email itself.
Does everyone know how to copy and paste the link into your calendar?
And how to, I'm not sure if it's what you mean, but like it says, you put in your Google Calendar as one of the links, and there's a few options there. There's a lot of steps involved in that. It's not like a smooth process, but it is automated.
And I use a different Google Calendar, so it's a lot easier for me to just cut and paste from the invitation right into the appointment that exists on that day. And I put HHS as every Tuesday until infinity, and then every Wednesday, and then I just keep adding them one by one. Then I get the pleasure of canceling those appointments when we're finally out of session. There's Representative Perry, welcome. And Representative Griffin has joined us. So if you're viewing the live stream, this is really just sort of a organizational session. We get lots of reports, and our analysts have a proposal for how we deal with reviewing them hearing about them and moving from there. So that's really what we're doing for the next 20, 30 minutes. So good morning, Representative Griffin. So I think since we are all here, maybe are pretty well represented, and maybe to save some time later on, we could go ahead and introduce ourselves now. So Representative Zager, would you start off?
Good morning. Thank you, Senator. My name is Sam Zager. I represent District 41 in Portland.
Representative Lemlin?
Good morning, everyone. I'm Michael Lemlin. I represent House District 88, Chelsea, Jefferson, Whitefield, and half of Nobleboro.
Representative Perry?
Good morning. I'm Ann Perry. I represent House District 140, which includes the communities of Indian Township, Baileyville, Barron, Callish, Charlotte, Robinson, Perry, Pembroke, and Pleasant Point.
Representative Stover?
Good morning. My name is Holly Stover. I represent House District 89, including the towns of Boothbay, Boothbay Harbor, Southport, Edgecombe, Westport Island, and part of South Bristol.
Representative Jabner?
Good morning. I'm Representative Kathy Javner. I represent House District 141, which is located in Penobscot and Washington counties.
Representative Craven?
Yeah, good morning. Thank you. I'm Robert Craven, and I represent House District 59, which is part of Lewiston.
Representative Griffin?
Good morning. My name is Abigail Griffin. I represent House District 102, which is Glenburn, Pedescig, and Levant.
Senator Moore?
Good morning. I'm Mary Ann Moore, and I represent Senate District 6, which is all of Washington County, as well as Goldsboro, Winter Harbor, and Sullivan in Hancock County as well.
Representative Meyer?
Thank you, Mr. Chair. I'm Michelle Meyer, serving Southern Maine's House District 2, which is all of Elliott, where I live, and parts of Kittery and South Berwick, and I'm the House Chair.
And I'm Ned Claxton. I have the honor of representing the folks in Senate District 20, which consists of Auburn, Minot, Mechanic Falls, Poland, and New Gloucester. And the staff that makes this possible includes Anna Broom.
Hi, I'm Anna Broom. I'm one of the legislative analysts in the Office of Policy and Legal Analysis.
And Sam Senf.
I'm Sam Senef. I'm the other legislative analyst in OPA.
And our clerk, Karen.
Hi, I'm Karen Thomas, and I'm the clerk of the Health and Human Services Committee. And if you need assistance, please email at hhs@legislature.maine.gov.
Very good. Thank you. And you've already helped several people get into the meeting already this morning, and we haven't really gotten started. All right. So I will turn it over to, I'll defer to you, Anna and Sam, about laying out a format for how we deal with incoming reports that we need to process.
Okay, so we just thought that we would begin the process of dealing with the book reports today. And so I just, as a background, I want to remind you about Joint Rule 353. I think it's Section 8. And this is the section of the Joint Rules that authorizes committees of jurisdiction to introduce a bill during the session to which the report is submitted to implement the recommendations on matters relating to the study. And that's because a legislative study or a non-legislative study don't have the authority to do that themselves. So that's the purpose of you looking at reports, is if you want to act on them in a legislative way, you have the authority to do that. So, you know, for the last few years that we've been assigning each report to a committee member to review, to summarize and present. And occasionally we hear the reports being presented by the authors. So we thought that this would be a good time to assign those, since you have this for half an hour spot. But we also have a slight change to the process this year. So the annual reports that you get every year will continue to be assigned the way that they always have been. And also any reports that are pursuant to letters. And the reason that letters are different is because you actually don't have authority to report out a bill that comes from a report that is pursuant to a letter, because that joint rule applies to acts, resolves, and joint orders. And letters, I mean, when you write a letter to somebody asking them to convene a group to do some kind of project, you're doing that on good faith. There's no legal authority for that whoever you're writing the letter to actually do that. And so that follows in terms of when you get the report back, you can't report out a bill. So those annual reports that sort of tick over and any report that comes in pursuant to a letter are going to continue to be assigned. But the thought was that the one-time reports, or sometimes they're a limited series, for example, those caseworker reports that you get that were pursuant to a resolve a couple of years ago, that there's 2 or 3 of them, or any new report, we're going to be endeavoring to have those presented to you. And you already got a little bit of a taste of that last night when I sent you an email reminding you about the pharmaceutical opioid charge report that you got back in July, I think. So you probably didn't even, you were probably like, I am not paying attention to legislative email right now from my analyst in July, and that's okay. So anyway, you got that one back in July, and that's a new report. It actually would be one of the, that one's actually a little bit different in the sense that that was a bill that came out of the Judiciary Committee, so it wouldn't necessarily have rung any bells anyway. But anyway, the point is that's a brand new report. And so this afternoon, when Gordon and Dr. Pollard do their presentation, they will include a few minutes about that report. Most of that presentation will not be dealing with that, but they will take a few minutes to talk about that report. So that was why you got that email yesterday saying, here's the report. If you want to have a look at it ahead of time so that you've got questions, you can do that. So the thought was that those one-time reports, new reports, limited series reports, we will have whoever authored those reports to come and present them to you. And then if you choose to, you can report out legislation. Obviously, it's your opportunity to decide or to ask if legislative action is required from you. And, you know, oftentimes the answer to that question will be no, but it's a, you know, it may be that they, you know, part of the purpose when you send somebody, a group off to look at a particular issue is, what do you need? And so that's your opportunity to do that. You can also report out a bill for any annual report as well. But the thought was that when you ask somebody to look at a specific thing one time, or maybe 2 or 3 times, that maybe you would like to know what the results of that were from the authors of that report. So you're going to see a lot more of those briefings and presentations this year. There are, however, a whole lot of... Yes.
We thought that'd be a good way to have people who are really comfortable and familiar with the material present stuff that was important enough for us to pay attention, particularly close attention, and then have a chance to ask them questions.
And there's certainly no intent here that you don't look at the reports. It may be easier for you if you look at the reports ahead of time, and then somebody comes in to present it, you will be able to ask questions. So this is not intended to be, oh, you don't need to ever look at these reports again. That's up to you. But we also have a lot of reports this year, one-time reports or new reports that are related to child welfare or children's mental health. So a lot of those are going to be chunked together. We have a presentation from OCFS scheduled for the afternoon of the 27th of January, and there's a whole lot of reports that will come up under that. So if you want to look at those ahead of time, you can. So if it's okay with you, I'm going to share my screen. The chart you've seen before, it should look familiar. Can you see that chart?
Now, yes.
Good. So I have to put you all in the middle because I need the beginning and the end. So you can see, for example, the one at the top there, the family reunification policy, actually the top 3, the reunification policies report, the kinship care navigator report, and the family first report. These were all ones that came in from Molly, maybe the end of last week, or maybe it was the beginning of this week, I don't remember. But there were 3 of them that all came in at the same time. Oh, I guess they came in on the 7th. And so that's why that column now says DHHS 127, because those are all related to child welfare or children's mental health. And when you go down the chart, there's a whole lot of them. You can see the Children's Behavioural Health Annual Report and the Child Welfare Annual Report. Those are 2 of, those will also be included. There's a whole lot of those. So I definitely encourage you, I'll send out this chart after today's meeting, and I'll definitely encourage you to have a look at any of those reports in preparation for that meeting, because that will be your opportunity to ask questions about them. We also recently got the long-term care, the family caregivers report, which is certainly a report that Representative Craven is intimately familiar with. And we will have Brenda Gallant come and present that report. We haven't got a date for that yet, but we will. Oh, actually, that's a letter that's unrelated to it, not directly related. She will address that at the same time. So this is one of those ones that's actually a letter. And if Brenda Gallant wasn't coming in anyway, then we would assign it. But since she's coming in anyway, that was just easier for her to do that. We have Main State Housing coming in to do the Fuse report, which was a one-time one from a Resolve. And then we also, this one on the rights and protections of acquired brain injuries, we're working on a date for that. And then we obviously have Christine Alberius coming in on the 25th, and she will talk about the Child Welfare Ombudsman annual report, which is one that actually goes to the entire legislature, not just to this committee. And then anything that has a blank in this column F, these are ones that in a couple of minutes we'll ask for volunteers for. But I'm going to go down a little further. You can see more from DHHS for 127, a couple of others that we've identified as one-time reports that we will have somebody come in from the department. It may be Molly, another couple that are ticking over. And this is number 28 is the one that I mentioned earlier and sent out last night. That's the opioid medication product registration fees report, which is a big mouthful. We'll also have the person from the Board of Pharmacy. If you have questions for her, she'll also be present. And then some more annual reports, and lots more department ones related to 127. And then we have a few that weren't done from last year. I think we'll have an offline conversation about what you want to do about those ones. And there's just a couple of them, 15, 16. There might be one later on, number 8. So that's the plan for that, and unless somebody has a sort of objection to that. So I'm going to stop sharing for a minute, but I'm happy to put it back up in a minute, but I can't see everybody first. If you would like to go ahead and assign well, first of all, are there any questions about that? Are there any issues? I'm sure that all makes perfect sense. Would you, since you have 10 minutes before Dr. Shah comes, would you like to do volunteers for the reports that are available, or would you prefer that I just sent it and had you all do a free-for-all? I think that's a question for the chairs, I guess.
Well, as long as Representative Javner gets to do the water report, then I'm fine with whatever we work out. So what other people? Do you want to go down the list and volunteer now and then send out the list? Because there'll still be blanks probably.
Sure. Let's do that.
So I'm going to open it back up again.
As long as we're here.
I just didn't want to assume. So and I've got 2 or 3 that are not on this chart that we can also assign that just came in. So the first one is the Alumni Transition Grant Program. You know, this is one that's related to aging out of foster care, I believe.
I'd like to take that.
Okay, let me write that down before I forget, Representative Perry. Oh, got a chart. Okay. All right, then the Marijuana Advisory Commission report.
Don't all jump at once. I'll do that one.
All right. So the next one is a one-time report, but it's a letter, which means there's no authority to report out a bill. This is from LD 48, which I believe was Representative Brennan's bill. And this was about supportive housing services to prevent homelessness.
Happy to do that one.
Okay, that one's a whole page, so that will be nice, right? Representative Zager?
Maybe I'll do another one then too, but I'm interested in housing stuff.
What you just said though, Anna, about not introducing legislation, it's still within the realm of possible that if we see something really outstanding, we could apply through Leg Council for a special exemption, or bills could be created for the next session in that normal cycle.
You can ask for a joint order. If you want to report out a bill, somebody can put in an after deadline bill, or if you have a vehicle that you think makes sense, then yes, you can.
Yeah.
Yep. The next one is the CDC Drinking Water Program Annual Compliance Report.
Don't everybody jump at once, please.
Well, we had your name on it, Representative.
Oh,
Jordan.
good. Oh, that's good. Well, you can keep it there. That's perfect.
On my
So you would-
screen, it already says Chabner.
Well, I wasn't going to assume Representative Javner. Okay, then the next one is the quarterly report. There are 2 quarterly reports on rulemaking. Each one of these should take somebody about a minute. If you would like to even not do that one, I would certainly understand. Representative Javner did one of those last year. She knows how exciting it is. Those are just the reports that are a record of all the rules that were made in the last quarter. You also get an annual report, and you get a notice for every single individual report. So you could decide as a committee that you don't want to review those, or you could have somebody review them, and it could be quick.
Why don't we take them off the list? We've
All
got
right.
plenty to do.
I think that makes perfect sense. But I wouldn't want you to not know that they're there, and you'll still receive them as reports in your email. The syringe report for 2020, the annual report.
I'll do that one.
Okay. She was quicker than you, Representative Sager.
And she's more senior too.
How about Sentinel events? That's a big one.
I would take that one.
Okay. And then the newborn hearing report.
I'll take that one.
Okay. Another water report. This is the Drinking Water State Revolving Fund. Nobody wants water. Okay. Birth defects report. Where am I going? Bottom of the page. Yeah, the CDC birth defects program report.
I'll check that.
We're going to cross off the next one because it's quarterly. The tobacco prevention and control.
I'll take tobacco.
Okay. And then the Death with Dignity annual report.
I'll take that
April.
one. Yeah, I'll do that one, Anna.
Thank you.
Mhm.
And then actually the Children's Cabinet annual report. This is also quite old, so I would certainly understand if whoever just takes it decides it's too old. I'll get that, but somebody should take it.
I don't mind taking it.
Was that Hartley?
Yes.
Yep.
You want to advance the screen?
Oh, I'm sorry. Yep. And okay, so that's I'm hearing myself twice. So then you have a couple of, can somebody turn me off because I'm feeding back here? Somebody needs to mute their screen. Okay, that's better. So then we have a couple that, like I said, we'll talk about off mic, whether you want to include those or not. So I'm going to stop the share, but I do have a couple more that came in. So yesterday you received the annual report from the Acquired Brain Injury Advisory Council. If somebody would like to take that.
I'll take that.
Okay. And then we also received the letter pursuant to LD 1657, which is the one about, this was the bill about the electrical power backup and assisted living.
That was a bill from Representative Babbage, right?
Yes. Nope. Okay. The other report that we did receive that we won't be assigning was from Brenda Gallant, which was the caregiver, the family caregivers report, and she will come in and present that. So that won't be assigned. And we also did receive, about 3 minutes before you all started, the Treasurer's report about the Tobacco Settlement Fund. Would anybody like to take that? That one's it's literally just about the money that comes in. There's no policy involved in that particular one, but it is tobacco settlement money.
Representative Baker had his hand up.
Representative Meyer wanted that because of the tobacco tie-in with the other one.
No, go ahead, Sam. You can take that.
Okay.
Okay. So that is all of them, except the ones that were not popular and nobody wanted. So I will send out an email about that, and maybe a couple of people who are not here today might sign up for those, or maybe nobody will review them. So that's me done, and you should be, I don't think I see, you should be hearing from Dr. Shah and Molly any minute now. Did they get a reminder too, Karen?
I'm sure it's no surprise to Molly. She's been getting questions and passing them along. So I assume.
I can resend the link to her as well, just in case they have an issue.
And while you're doing that, we can give Representative Connor a chance to introduce himself.
Chair, my name is John Connor. I represent House District 58, which is part of Lewiston.
Thank you. So we're pretty close to start time. Because it's a webinar. I asked that Karen make me a host, make sure that's possible. We might as well go ahead and get started. The format is that Dr. Shaw and Molly will be here with us until 12. The idea is to spend 45 minutes trying to address the questions that were submitted by the committee after being solicited on Tuesday and Wednesday, and give Dr. Shaw a chance to answer as many of those, as well as give us whatever updates he thinks are appropriate. With the remaining 45 minutes, we can go around the horseshoe, and everybody will have a chance to ask a question. I do ask, since there's likely to be lots of questions, that you keep the question itself pretty succinct, and avoid some of the run-up sometimes that we get from other folks as they introduce things. So if we can keep your questions succinct, that'll give everybody a chance to at least ask one question and get an answer. But I'm hoping we can go around once or maybe twice. Any questions about that? Not seeing any. Good morning, Molly.
Good morning. And I don't have a question so much as I know there were a lot of questions and we were getting them until this morning. And so I think what Director Shaw is going to do is maybe shorten that early piece, talk about some of the themes that we've been working on and that you covered in your questions, and then defer to you to sort of prioritize which of those remaining questions you want to cover. So I imagine we'll have time to go through the horseshoe twice, certainly, and but just want to prep you that beginning portion may be a little bit shorter, but that's to sort of let you prioritize the topics you want us to cover.
Very good. And before we welcome Dr. Shaw and Jackie Verrill, I apparently have been asked to permission to remove jackets. I sort of think of that as a standing offer, but Representative Zager wanted to know if that was okay, because he's too warm at his place. So let's welcome Dr. Shaw. Good morning, sir, and Jackie Verrill.
Good morning. Good morning, Senator Claxton, and good morning, everybody. Thank you all so much for the opportunity to meet with you today. I'm really excited to discuss where we stand with respect to COVID-19, and certainly take and discuss your questions and dive into topics that are of primary importance. As Molly Bogart, I believe, mentioned, in light of the fact that there are nowadays so many different topics that one could cover with respect to COVID-19, what I humbly propose is I provide a few opening remarks that set the landscape around where we are, but then turn it back over to our chairs and our co-chairs to help navigate the questions, such that we can maximize our time and make sure that I'm talking about the things that are of most importance to the committee. Senator Claxton, Representative Meyer, if that is workable for you, then I will dive headlong in.
Please proceed.
Okay, very good. Well, thank you. Thank you. And again, members of the committee, thank you all again for the opportunity to meet with you and discuss where we stand today. As of this morning, Maine now logged 158,087 cases of COVID-19, sadly resulting in at least 1,626 deaths. Those are sad numbers and are well beyond what I think anyone would have imagined our state, to say nothing of our country or the entire globe, would have imagined we'd be at the very beginning of the pandemic, when we first started learning about it at the end of 2019 and began grappling with it early in 2020. Much has changed since then. For example, just today, our positivity rate reached a new high point in the pandemic. It now stands at 20.8%. As I'll talk about in a minute, much of that, if not all of that, is driven by the Omicron variant. But that positivity rate comes at a time when our testing volume is also at a high point. As of this morning's data, the state of Maine is conducting 848 PCR tests for every 100,000 people in the state every single day. That too is a high point with respect to PCR testing all across the state. We recognize that testing availability in our state remains a challenge. And that's why in recent weeks, the Maine CDC, Maine DHHS, working with our close partners at the Maine Emergency Management Agency and the Maine National Guard have, for example, here in Augusta, stood up additional testing opportunities at the Augusta Armory, building on the successful vaccination effort that we started in early December, both of which were in direct response to individuals alerting us to shortages, first on vaccines and then later on testing. We've also taken steps to expand testing elsewhere in the state. For example, working with local officials to expand testing offerings in Westbrook, as well as at the Portland Jetport. More recently this week at the Cross Insurance Arena in Portland, all while maintaining testing operations in other parts of the state, for example, like in Calais. We know we have more work to do there. We've been working, for example, with federal partners to look to see if there are ways we can bring additional testing to Maine to make sure that if someone is experiencing symptoms, or if someone or their child has been exposed to COVID, they know when, where, and how to go and get tested. We're hoping to be able to launch additional locations if we can in coming days. No announcements on that today, other than to say that we recognize that testing access remains a challenge and we're committed to working toward it. But a consequence of the high numbers of cases that we've seen has sadly been an increase in our hospitalizations. As of this morning, there are 436 people in Maine hospitals with COVID-19. That too is a sad and grim high mark throughout the pandemic. Of those 436 people, 103 are in an intensive care unit bed and 333 are in a non-intensive care unit bed. It is that increase in non-ICU hospitalizations, that 333, which is driving the most recent increase in total hospitalizations. Of those 436 people, 53 are on a ventilator. And statewide, as of this morning, there are 41 adult ICU beds available across the state. As I've hinted, much of the increases that we are seeing in cases, hospitalizations, positivity rates, and sadly, even on deaths, has been driven in recent weeks by the arrival of the Omicron variant across the country and, of course, here in Maine. Maine CDC epidemiological data show that the Omicron variant is the dominant variant across the state of Maine right now. Omicron, in many respects, is scientifically distinct from previous versions of COVID-19. It is far more contagious. It's thought to be approximately 3 times as contagious as the Delta variant, which itself was more contagious than prior variants. It also can cause infection much more quickly after exposure. This is what's known as the latency period, the time between being exposed and the time when one can be capable of causing an infection. The latency period for Omicron, that too is shorter than with previous variants. We also have much better data on when the bulk of transmission occurs, particularly with Omicron. And what we've learned is that with respect to the newer variants of the virus, the transmission is front-loaded. Shorter in the earlier in the course of someone's illness is when the bulk of transmission is occurring rather than on the back end. These distinct scientific and biological differences with the Omicron variant in many respects change the game. They mean a virus that is capable of jumping from person to person more quickly, more easily, and sooner. That means we have to adjust the way that we think about COVID-19. What hasn't changed, however, is the importance of being vaccinated and boosted. There too, I am pleased with the progress that Maine has made and is continuing to make. As of this morning, Maine is administering exactly 5,703 doses of COVID-19 vaccine every day over the past 7 days. As a result of that, 76.5% of the entire population of the state, of every single person in the state, are fully vaccinated. This puts Maine in the #3 spot in the United States. Indeed, a large part of that is because of the efforts that we have taken to make vaccines available. For example, our site at the Augusta Armory is coming up soon on having administered its 10,000th dose, to say nothing of longer standing vaccination sites. For example, those at the Auburn Mall or the site in Sanford operated in partnership with York County EMA, which have been online continuously throughout our vaccination efforts. We've got more work to do there, particularly on getting children, the youngest group of children, those between 5 and 11, continuing to get them vaccinated. We've made strong progress, but given that they were the most recently eligible group, we've got more work to do there. I typically talk about COVID, but it's also important to note that there is other good and important work that's going on at the Maine CDC. We continue our work around issues grappling with the so-called forever chemicals, PFAS and PFOA, working in partnership with our colleagues at the Department of Environmental Protection. We have not lost sight of the fact that COVID is not simply an infectious disease, it's also a disease that has profoundly affected individuals' mental health and brought on even greater challenges for those who are grappling with substance use disorder. And we've been pleased to work with our colleagues at the Office of Behavioral Health, as well as across state government, to continue focusing on prevention, as well as sound public health strategies for mental health and substance use. Similarly, our work around the HIV crisis, the other infectious disease that remains out there in high numbers, continues. Indeed, not long ago, just 2 days ago, we received some encouraging news from the National Ryan White Program, the Part B program that works with individuals who need HIV assistance, care, and support. The most recent report from the Ryan White Program found that among all states in calendar year 2019, Maine had the highest rate of Ryan White participants who were virally suppressed for HIV, 93%, tying New Mexico and New York. Similarly, 74% of all clients, regardless of whether they are on antiviral treatment, were being reported as virally suppressed. Maine also scored in the #2 spot among AIDS drug assistance program states that had the highest rates of viral load suppression in calendar year 19, coming in 1 percentage point behind Idaho, with Maine being at 94% and Idaho besting us by a single percentage point at 95%. I mention these things partly because it demonstrates that even while we have grappled with the COVID-19 pandemic and led the way amongst all states, Maine CDC staff have not missed a beat on other important public health challenges. I also want to note that we ourselves have not taken the focus off of those other challenges. We've been able to simultaneously address needs surrounding and presented by COVID-19, while also ensuring that we have focused on other public health challenges at this time. Thank you all for the opportunity to join you. I very much look forward to the discussion and the questions. Senator Claxton, Representative Meyer, I will turn things back over to you.
Thank you for that, Dr. Shaw. From the questions that you received, did you have a sense of which were the ones that might be the higher priority for members of the committee? Or do you want us just to go around the horseshoe?
Senator and Representative, I am at your disposal. We reviewed the questions, but I recognize that there were quite a few, and I don't dare to presume what is of greatest importance to the committee. So,
Okay.
Senator and Representative, I will defer entirely to you.
That being the case, thank you for that. Let's start with Representative Zager. Do you have a question for the doctor?
Yes, thank you very much, Senator. First, I'll start off with an apology that I missed the deadline. I had wanted to see your weekly briefing yesterday, forgive me if this is not among the ones that you received ahead of time. Let me just look at my. So I have sort of a short-term and a long-term question. The short-term is really kind of quick regarding the availability and distribution of the oral treatment Paxlovid. What do you know about it? And then the long-term question kind of goes back to what you were touching on with the other infectious diseases, but as the legislature is considering bills with horizons that go years out, what suggestions do you have for how we might account for COVID-19 and other infectious or non-infectious public health threats? I realize that's a big one, and you might want to just keep it light on.
Thank you, Representative Zager. And I know, given your background, that these are both of primary importance. Let's start with Paxlovid and more generally oral antiviral therapies. Of the two that have been FDA authorized, Paxlovid is the one that we are watching, and we are the more excited about, given its higher effectiveness at keeping people out of the hospital, approaching 90% effectiveness. That is obviously very exciting. In order for it to gain that effectiveness, it must be deployed early in the course of illness, as you're well aware, and that necessitates early, rapid, affordable, and easy access to testing. So we are working with providers to couple the rapid testing with rapid access to the drug and the medication. It's an exciting therapy, and I don't want to discount it for a second. However, the challenge with Paxlovid right now is around the supply. Maine, for the month of January, received 240 patient courses of Paxlovid. That's it. We're logging 4 to 5 times that many cases every single day. For the next ordering period, we did see an increase in our allocation from 240 to 360 patient courses for several weeks. We could easily utilize that much in a matter of hours, let alone over weeks. So the challenge with Paxlovid right now is truly on the supply. We understand and have worked with and been briefed by the Biden administration on their efforts to increase the supply, working with Pfizer, increase the supply manufacturing. And I understand that increases of that sort are in the works. We're hopeful that Maine will quickly be the beneficiary of those so that we too can have more of that agent. The other is the Merck product molnupiravir, which we are receiving in greater numbers, roughly 1,000 patient courses, which is still not enough, but greater than what we're getting for Paxlovid. Those greater numbers are tempered by the lower efficacy. Molnupiravir, whereas Paxlovid is approaching 90% effectiveness at reducing hospitalizations, molnupiravir is in the 30% range. So there is a bit less enthusiasm, but let's be clear, we're not going to turn any of it away. A drug that reduces hospitalization rates by 30% is a step forward from 0%. So that's where we stand with those oral antivirals, to say nothing of monoclonals and such, which we can discuss. A bigger picture, the horizon for infectious diseases. Dare I make another effort at opening up my crystal ball? But I will mention it in 2 axes. The first is, of course, COVID will continue to be with us in different forms during different times of the year, but we are soon approaching a point at which COVID will be endemic. COVID endemicity is as much an approach to thinking about infectious diseases as it is a biological phenomenon, but quite clearly COVID will be with us in varied and different forms. But other infectious diseases will start materializing as folks are getting back to their lives, be it foodborne illnesses, as individuals get back out there. And so making sure we can support the health inspection program is going to be critical. And then as we think more generally we've got to take a national approach toward thinking about preparedness for the next pandemic. I know no one wants to think about the next pandemic while we're still in the throes of the peak of the current one, but if we don't do that, we're not doing ourselves a service.
Thank you, Dr. Shaw. Before we go to the next question, I'd like to give Senator Baldacci a chance to introduce himself if he would like.
Thank you, Mr. Chairman. My name is Joe Baldacci. I'm State Senator from District 9. I represent the city of Bangor and the town of Herman. Good morning. Thank you, Mr. Chairman.
Thank you.
Morning.
Representative Lemelin, a question?
Yeah, question and a concern. I could use up this whole hour with my concerns and questions from my constituents. First of all, my concern is the vaccine, of course, and the forcing of vaccine on people. And here's why my constituents and myself have a huge problem with this. And hopefully maybe some things can be cleared up here. First of all, the vaccine, it was testified yesterday that of the 436 people hospitalized, 30.5% of those people hospitalized are vaccinated people. Now, people don't talk about that. The lady just talked about 69.5% are unvaccinated. But the key is not whether or not unvaccinated people are hospitalized or not. The key to the people of Maine is vaccinated people are hospitalized. The second testimony was that 20% of the people on ventilators are vaccinated people. So if the vaccine works, then, and I've heard Dr. Shaw and other people from the CDC and HHS brag about this vaccination, that it's saving lives. Well, to me, and it's stopping hospitalizations. Well, if 30.5% of vaccinated people are in hospitals and 20% of vaccinated people are on ventilators, why are we forcing vaccinations on people? This makes no sense to me. My second concern is,
Can we give him a chance to answer that question? And,
sure.
And then go around so everybody has a chance?
Certainly, I'd be happy to. Representative, there are two factual errors in your question that I think explain my perspective on this. The first is the notion that anyone is being forced to take the vaccine. That is not true. No one is being forced to receive the vaccine under any circumstances. The other,
excuse me, Dr. Shaw, I don't mean to interrupt you, but people have been fired from hospitals who didn't take the vaccine. Now, that's forcing somebody, and I'm just going to end right here, but that's forcing somebody to take the vaccine if they're going to be terminated from their livelihood. That's all I have to say. Thank you.
The other is the notion that there are a high number, as you framed it, high number of folks who are hospitalized despite having been vaccinated. And that is the case. No vaccine, no medication, no therapy eliminates 100% the risk of an unfortunate outcome. There has never been a medical product, a medical device, a drug, an intervention, a surgery in the history of medicine that is 100% effective at all times for all people in all circumstances. Indeed, if someone's view is that they will not take a drug or a device or a therapy unless it is absolutely guaranteed to be 100% effective, then they're going to have a hard time accepting any kind of medical intervention. The vaccines are not 100% effective. What they are is extremely effective at reducing the relative risk of hospitalization. So when we look at this question, the operative inquiry is, what is your risk of experiencing a bad outcome, like a hospitalization, if you are vaccinated versus if you are unvaccinated? And there we have data on this exact question. Thankfully, the US CDC receives data from states and is able to tabulate on a national level what it looks like, what your risk is of, say, being hospitalized or dying if you are vaccinated or unvaccinated. A lot of these data are very, very much available on the CDC's website. I'll just go through them really quickly here, though. Let's just start with the risk of testing positive for COVID-19 if you're vaccinated versus unvaccinated. Nationwide, in October of last year, an unvaccinated person had a 5-fold higher risk of testing positive than an unvaccinated person, than a vaccinated person, a 5 times higher risk if you're unvaccinated. That risk varies considerably by age group, with older individuals experiencing even higher rates of hospitalizations or cases, especially if they're unvaccinated. Let's talk about the risk of death. In October of last year, based on national data, an unvaccinated person had a 14-fold higher risk of dying from COVID-19 compared to a fully vaccinated person. There too, there are significant stratifications on age. Hospitalization, which you raised, is an important metric as well. For adults, from January through November of 2021, the risk of hospitalization for unvaccinated adults nationwide was 8 times higher for the unvaccinated as compared to the vaccinated. So when we take a look at all these these data points, the question is, do the vaccines work at what they were designed to do, which is reduce the risk of being hospitalized, of being on a ventilator, and dying? Do they eliminate that risk? No, nothing in medicine ever has eliminated a risk. Now, Representative, I know you take a look at the numbers and see, well, wait a minute, if 30% of people in Maine who are in the hospital are vaccinated, how does that compute with what I just said? This has to do with the phenomenon in statistics referred to as the base rate effect. One of the byproducts of Maine having such a high vaccination rate, 76.5% of every single person in Maine being fully vaccinated, is that a bad outcome like a hospitalization can still occur. But it's more likely to occur because there are so many vaccinated people. Something that occurs rarely because there are so many vaccinated people may make it appear as if the vaccine is not working. But when you take a look at the relative risk, which is the numbers that I provided, it's strikingly clear that the vaccines are doing exactly what they are designed to do.
I don't
Senator.
agree, and the numbers don't agree either. But because first of all, Dr. Shaw, I've asked 1,000 people right now, everybody I come in contact with, I ask them one question. Do you know that 671 people in the first 9 months of the vaccine, and this was testified in a court of law with you, 671 people within 9 months of the vaccine being given out have died of no known causes within 28 days of the vaccine. Nobody knows this fact. This should be on the front page of the Press Herald, and in my opinion, you should be telling everybody this so that they know that. And you said you don't want to investigate this, and this blew me away because this is a huge number. 671 people. That's more people than died in the first 9 months from COVID itself. And those 671 people died of no known cause within 28 days of taking the vaccine. This is huge. This is scary. Far more scary than the deaths of COVID. That's my last question and comment. Thank you.
Your question there too relies on an assumption that is not factually correct, which is that the vaccine played a role in causing those deaths. There is no evidence whatsoever that the vaccines have played a causative role in the deaths of any individual. Indeed, based on the data that I shared, the relative risk of dying after vaccination is significantly lower after you get vaccination rather than had you not been vaccinated at all. This is a classic example of correlation not being the same as causation. Fortunately, in biomedical science, we have a way of understanding whether something is a correlative effect or a causative effect, and that is through a randomized clinical trial. A randomized double-blinded clinical trial allows us to isolate a variable, such as the one that you noted, the risk of death, and take two equivalent groups of individuals and apply an intervention, in this case, a vaccine, and see if there are outcome differences between those two groups. The three vaccines that are available in the United States have undergone significant testing through very large randomized clinical trials. These are trials that are, again, designed to determine whether the outcome that you postulated as being true, a risk of death at 28 days, actually occurs when you give the vaccines or a placebo to tens of thousands of people. Indeed, when these vaccines were studied and the data were reviewed, there was no risk of death in the vaccine group relative to the placebo group.
Representative Stover, you had a question?
Thank you. And thank you, Dr. Shaw, for your leadership. I have a question. I received two separate requests from two separate parents regarding two separate situations. One had an adult child released from the county jail system, and one had an adult child released from the state prison system, Maine State Prison. Both wrote to me within a 2-week period of one another recently. And both had concerns that although their adult children had wanted a vaccine, one was told he was put on a wait list, and one, it didn't either happen in time before the release, but it didn't happen, even though both had expressed a desire to have one and were unvaccinated. I'm just wondering what collaborative efforts are in place between the Maine CDC and the Department of Corrections, realizing the county jail system is a little bit different because it's county-based, but has some guidance, but the state prison system, what efforts are in place to collaborate with them to ensure that inmates who want a vaccine and may not have a vaccine can actually get one prior to being released? Thank you.
Thank you. Thank you so much for that question, Representative Stover. I have been quite, I've been pleased and valued the relationship and the collaborative effort that Maine CDC and the Department of Corrections have had in place since long before our first case of COVID was ever diagnosed in the state of Maine. Before we even had our first case, way back, I want to say maybe January or February of 2020, Maine CDC and the Maine DOC sat down at the very table that I'm speaking with everyone from, because we recognized that this would be a challenge in congregate settings, such as jails and prisons. Commissioner Liberty and Deputy Commissioner Thornell and their medical team met again at this very table to talk about how we would collaborate on COVID. And indeed, every day since then, literally every single day, I have had a call, or they are on our incident command call, so we are coordinating. I've been pleased with the rollout of vaccines within DOC, particularly when you look at the fact that for residents of DOC, they are vaccinated at a higher rate than the general population in Maine. So an average resident of DOC is more likely to be vaccinated. Now, they're in the 80% or so threshold, and we're at 76.5. But you see the point I'm making. Now, with respect to the constituents who reached out to you, you're right. County jails are a bit more under the purview of DOC, or indeed perhaps independent unto themselves. But within DOC, vaccines and boosters have been regularly offered since, and again, we've been pleased to be able to collaborate with them on the supply of vaccines and such things. I don't know that in recent days or weeks they are offered. In terms of the schedule on which they are offered, I would refer you to DOC, but we have worked very closely with them on all aspects of COVID, including and up to vaccines, boosters, monoclonal antibody therapies, so on and so forth.
Thank you very much. Thank you very much. I'll follow up with the constituents and DOC.
Senator Baldacci, have you got a succinct question for the doctor?
Doctor, it's a pleasure to have you here. And really, I think it's important for you to know, as we said last year, how important your work is and how much many of us here are grateful to the work there. And I think, if whatever we need to do, we definitely would support. But I do have a couple of questions. One that stems from some of the testimony that we received the other day on a legislation. And I'm not going to ask you to comment on the legislation. I'm going to ask, but I feel that there's a significant amount of disinformation and bad information and bad science that is unfortunately influencing this regard. So first of all, is there any evidence that being vaccinated causes COVID? Deal with that one first.
Yeah, Senator, I'm going to, in the interest of brevity, no, there is no such evidence.
Is there any evidence that pregnant and breastfeeding women should not be vaccinated?
There is no such evidence. In fact, it is the opposite. According to the American College of Obstetrics and Gynecology, as well as the US CDC, women who are pregnant or have just recently given birth should indeed definitely be vaccinated. That is in part because of worse outcomes were they to get COVID.
Is there any evidence that these vaccines are not effective in terms of reducing hospitalizations?
There is no such evidence, Senator. Indeed, as I recited some of the data earlier, the evidence points in the opposite direction, which is that the vaccines are exquisitely good at reducing hospitalizations.
Last question is that there's been nearly 400 million doses of vaccines given out nationwide. And from your understanding about adverse impacts, what is the documented adverse impacts from the vaccine?
Well, Senator, the question with respect to adverse impacts is always one of balance. Given the risks of COVID, are the adverse impacts ones that are on balance? So there are adverse impacts with any drug, device, therapy, surgery. There are adverse effects with COVID-19 vaccines. They tend to be things like some pain in the shoulder, some fatigue. Those of us who've been vaccinated have probably had a day where they felt pretty crummy. Those are by far the overwhelmingly most common side effects. A vanishingly small, but a percentage of individuals may experience worse side effects. They may experience deficits in their in their nervous system, so on and so forth. Those are extremely rare, but we must discuss them because that is what being transparent entails. The question is, on balance, whether vaccination is worth it. And given what we know about COVID and the more than 800,000 people who have died, the 1,600 people who have died in Maine, there is no question in my mind, as well as the minds of the CDC, the FDA, the World Health Organization, and doctors and nurses here in Maine, that COVID-19 vaccination is absolutely indicated.
Okay. And are you satisfied with the vaccine mandate of healthcare workers and how it's been implemented and how effective it is?
Senator, I don't think of it as a mandate. It is a requirement of one's job. There are many requirements that each and every one of us has when we have to go to work. With respect to healthcare workers, there are already requirements in place for them to be vaccinated. These are long-standing requirements for vaccinations that go back for many years. The COVID-19 vaccine is a new addition to that. That being said, that quibble aside, I am satisfied with it, as are healthcare leaders across the state of Maine.
So moving on to the next question, Representative Perry, did you have a question?
Yes, I have a question, but it's not related to COVID. The question is, when you came on, Dr. Shaw, we were really had the charge of really rebuilding and enhancing our public health infrastructure. And I was, with all that is going on and knowing that we are dealt with this early pandemic while we're rebuilding, how is that going? How are we doing, and how are we prepared for the future?
Thank you for that question, Representative Perry. We've got to continue that work. I'm by no means here to suggest that COVID has resurrected the system such that it's mission accomplished. We've got to continue that work. we've taken steps to do so, even notwithstanding the pandemic. For example, in our public health nursing program, which is a vital part of the public health infrastructure, we brought on a skilled director of public health nursing, someone who led a force in another state, who's from northern New England, wanted to come back to New England, come back to Maine, but someone with years of experience in public health nursing. That individual, her arrival and her enthusiasm has allowed us to recruit more and make sure that we can keep building out our public health nursing program. So we've got more work to do there. Another element of our public health system that I think we now have a finer appreciation for, but not discussed as much, is school nursing. School nursing is a really critical part, obviously in recent weeks, months, years, for infectious disease management, but mental health counseling for at-risk students, so on and so forth. We've got more work to do there as well. And then, of course, the Maine CDC itself. We are still in the process of building back and hiring for important positions like health inspection, our drinking water program, to say nothing of our infectious disease program. We've made progress there. We've brought on a new head of our drinking water program, someone with extensive experience in the upper Midwest, but we've got more work to do across the agency. We're not slowing down. The pandemic, as you heard me note, has, although it focused the attention on COVID, we haven't stopped in other areas, including around infrastructure. I would be remiss if I didn't note that we are able to do that work because of the strong support of the legislature, and in particular this committee, whether it's on headcount, funding, programs. So we are not alone, and we thank you for that support.
Thank you for that answer. Representative Javner, your question.
Thank you, Senator Claxton. Thank you, Dr. Shaw, for being with us this morning. We really greatly appreciate it. My question does have to do with COVID. I was glad to hear you actually utilize the term transparency earlier. That actually has been my focus as I've thought about the questions that I would ask you and the department. Recently there have been two very conflicting articles that have come out in the news. One, day saying that no, there are no COVID positive healthcare workers, being at work in our healthcare system. And then another article comes out saying, yes, there are. Can you please clarify exactly what is happening with the COVID positive healthcare workers?
Certainly, Representative Javner. On December 23rd, the US CDC released nationwide guidance allowing healthcare facilities under certain very limited circumstances, to allow COVID positive staff to come back into a facility. The CDC's guidance recommended essentially a stepwise approach to that, indexing the acuity of the situation with the potential infectivity or the place in a course of illness of the worker who might be coming back, giving preference to workers who are asymptomatic, workers who have been vaccinated, so on and so forth. That guidance came out on December 23rd. It's a self-implementing piece of guidance. And I want to stress how rare those situations where a healthcare facility might need to bring back a worker may in fact be. The guidance itself is one that healthcare facilities can take on their own, read, understand, and implement, because it's a thorough document and it speaks for itself. In recent days, we've become aware, although there is no requirement that healthcare facilities report this to the Maine CDC, we've become aware that at least one healthcare facility has deemed itself to be in a sufficiently crisis mode such that they have opted to bring back on a limited basis positive healthcare workers. These are temporary measures designed to ensure that the facility can continue normal operations.
Thank you.
Very good. So to continue in the order, I will go next to Representative Connor.
Thank you, Mr. Chair. Thank you, Dr. Shaw, for being here. I've got two really quick questions that are more, 30,000 foot departmental level questions, if I may. Dr. Shaw, after Governor Mills' declaration of the emergency was allowed to lapse, the department declared it had its own public health emergency. When the department's public health emergency was declared, though, the timeline was pegged to that of the U.S. Department of Health and Human Services, their declared public health emergency. I know that the secretary renewed the federal declaration on October for 90 days. which I believe brings it to January 16th of this year. I was just wondering, what is the current status of that emergency? Has it been extended another time? If not, will the department's emergency expire?
Thank you for that question, Representative Connor. I'm not sure what the Secretary Becerra at the federal level. I'm not sure what his intentions are with respect to the extension. But as you noted, ours will be tethered to that. I can't speculate, as you know. I would be surprised if Secretary Becerra's Federal Department of Health and Human Services designation were to go out of effect, given everything that we now see around the virus. But I can't say that with certainty. If that were to happen, we would reevaluate ours.
Thank you. One more very quick one, Mr. Chair, if I may.
We'll give you a point for not feeling well, we've been told. So go ahead.
Thank you, sir. I appreciate it. Dr. Shah, I've had people that have reached out to me because they've heard in other states, other states have talked about, taking various steps, separating unvaccinated people from the vaccinated people. And I'm talking about more than just, requiring proof of vaccination to attend specific in-person events, but more broadly. Are there any discussions in the department about policies that Maine might implement to further restrict the activities of unvaccinated people here in Maine?
None that I'm aware of, or none that I've participated in.
Thank you, sir. I appreciate it. That's all I had, Mr. Chair. Thank you for the latitude.
Representative Craven.
Thank you, Mr. Chair. Thank you, Dr. Shah, for all that you do. My question is about guidance regarding COVID positive staff coming back to the hospitals, and wondered if the guidance had the positive staff working only with people who were infected.
Representative Craven, if I may, Representative Connor, I don't mean to backtrack a little bit, but my answer to your last question was needlessly bureaucratic. There's no reason for me to say none that I'm aware of. The answer is no, if I may, for the record. The answer is a clear and unequivocal no.
Thank you, Dr. Shah. I appreciate that.
Yeah, with that clarification, Representative Craven, the US CDC's guidance recognizes that there should be a stepwise approach to this. And one of those steps is that if a COVID positive patient needs to come back into a facility, such as a nursing home, there is a preference that is stated and is implied and is something that we've counseled facilities on, to have that staff member work only with COVID positive patients. That is often tenable, but not always. And so if not, then we go to the next step. But yes, the preference is for cohorting, as it's called, such that a COVID positive staff member is working only with COVID positive patients. That's the preference. We have to index that and calibrate it against the acuity that a facility might be facing.
Thank you.
Representative Griffin.
Thank you. And thank you, Dr. Shah, for being here today. I do have a question about how is the Maine CDC keeping track of any adverse effects of the vaccines? And how is the public informed about any adverse effects?
Sure. Maine, as well as other states and jurisdictions, we rely upon a national database called VAERS, among others, which stands for the Vaccine Adverse Event Reporting System. And anyone who has experienced an adverse effect, be it a patient, a healthcare provider, et cetera, is asked to and encouraged to input that adverse event into that national database. The benefit of that is that we don't just have Maine-specific data, but we have data from all across the country. That's what allows us to have a global view of what's going on with any vaccine out there, including the COVID-19 vaccines. Maine, as a participant, as all states are, in asking people to report into that database, that gives us a way to compare the experiences that are occurring all across the country.
Senator Moore, did you have a question?
I have several questions. I guess piggybacking on that, on Representative Griffin, if I may, Dr. Shah, thank you for being here. How many cases of adverse effects of the vaccine has Maine reported to the VAERS system?
I'd have to check the VAERS database to see what the latest number is. I'm not sure how many providers in Maine have reported as of this morning. I'd have to check the database to see how many such reports have been logged by individuals, Mainers, healthcare providers across the state into the database.
Okay, because as I understood, it's a law. It's required by law that if they
For providers, it is. For individuals, perhaps not. You can already see there's the possibility of duplicate reporting. But for providers, yes, they are. Actually, I believe it is. I'm not. I'd have to double check that to make sure my facts are correct. I don't want to give you any incorrect facts. But that database is open. It's accessible to the public. It is not a you have to be a doctor type of database. Anyone can query the database to look at reports that have been logged. And indeed, researchers across the country, including at the US CDC, utilize those reports to look for potential concerns with a number of vaccines that may be out there.
And Mr. Chair, may I ask just one other question real quick? The terminology that we are using, fully vaccinated, is that just the primary shots, or is it also the booster? I guess I'm trying to understand the numbers.
Thank you for that question. Just a clarification. I was just checking my notes. Yes, healthcare providers are required by law to report into VAERS. And Senator Moore, to your question about the terminology, right now, fully vaccinated entails the primary shots, either the one shot of Johnson & Johnson or the 2 shots of the Pfizer or Moderna. The other term, and there's now, there are different terms out there, but the other term that we're using, or the US CDC is using, is up to date, which includes both the primary shots as well as getting a booster.
Okay. Thank you.
Representative Meyer.
Thank you, Mr. Chair. Thank you, Dr. Shaw, for being here today, but more so for your service to the people of Maine. I have had an ongoing dialogue with my colleagues in the nursing profession who are vital to the safety of our students, and those are Maine's school nurses. I'm going to ask just one of the questions that I have gathered from the school nurses that I dialogue with, and it is as follows. Even though the data suggests that returning to school following 5 days of isolation is a reasonable approach as long as symptoms are resolving, school nurses are regularly seeing obviously ill students returning to school on day 6. Would you consider recommending testing on day 5 to determine next steps? In other words, return to school or continue to isolate?
For that question, Representative Meyer, and first of all, I appreciate your warm welcome. I'd be remiss if I didn't remind folks that I'm but one person in a team of thousands across the state, including the entire building here at the Maine CDC. They are the ones that do the work that I have the privilege of being able to discuss. With respect to the question that you raise, it's an important one. And the notion of whether a test ought to be required, recommended, or just provided guidance around for release from isolation is certainly one that has come up, certainly in the context of schools, as you raised. My view right now is that the US CDC has this about right, which is to say, first of all, for the students that you noted or that your colleagues in nursing have noted, who are coming back to school obviously sick, that shouldn't be the case. The guidelines are very clear. If you still have symptoms and they are not improving, you should not be released from isolation. Testing is not going to solve that. The solution to that dilemma, to the scenario you raised, is ensuring that those children are not coming back in the classroom. I say that recognizing that is not easy for parents. And that is one of the benefits of the shorter isolation guidelines. We hope that it does get kids as well as employees back out there. But for a truly asymptomatic individual, the benefit or the addition of testing on top of being asymptomatic, the latest models suggest that it doesn't add much. It can add something. I don't want to say it's zero impact, but the benefit of it seems to be somewhat marginal. Not zero, but in light of the challenges of obtaining tests, so on and so forth, my view is that the CDC has got this one right, which is they provide guidance for if you opt to take a test, then what to do with that result. Personally, I think folks should take a test if they're coming out of isolation. I think that's a wise and prudent thing to do. However, I recognize that that's not available to everybody. What we know about COVID is that after day 5, the likelihood of infection doesn't go to zero. It doesn't go to zero for quite some time, but it does go down to a level that we have to make a balance.
Thank you.
My question, Dr. Shaw, is at a somewhat different level. Can you speak to your reference or resource group with which you're frequently in touch about how they're making decisions in their arenas? And is there a breadth of opinions available in that group?
Senator, could I ask you to, I generally understand your question, but which group are you referring to?
I think you've referenced in the past that you talked to other directors of CDCs in other states and were in regular contact with them. Are they your primary resource group in terms of discussing things and getting an outside perspective, or do you use another resource?
Gotcha. So I have the privilege, another privilege and honor in my life is having the honor of serving as the president of that group, a group called ASTO, the Association of State and Territorial Health Officers. We meet several times per week for calls that go on for a while. And I'm one of the benefits of such a group, because it represents all state and territorial health officers, is that there is a diversity of views, particularly on new and emerging issues. For example, with respect to the guidelines, the recent guidelines around isolation and quarantine that Representative Meyer raised. I wouldn't call them, Senator, and so when I say diverse, then I mean these are health officers who come from a variety of backgrounds, infectious disease experts, folks who came from academia, folks who have a background in regulation, et cetera. And so everyone brings a different perspective to the table, and I've benefited greatly from listening to those discussions. I wouldn't necessarily say they are my primary group of information. My primary group for new and emerging information is the team here at the Maine CDC. I've got a team of experts, some of whom I've hired away from the US CDC, like our newly arrived state epidemiologist. As I referenced earlier, others who came from prominent positions in other states. We've recently brought on a new director of population health equity, someone who has deep experience in Maine. So my primary group is my staff here at the Maine CDC. I then also turn to counterparts in other states, as well as experts at the US CDC, if and when we have particular subject matter questions. Each of those groups is quite diverse. And if I may, Senator, I know time is of the essence, but I wanted to mention something that is near and dear to me. As a principle of management, I have a request into my team, which is that if you're in a meeting with me, not only do I want you to disagree, I actually think you have an obligation to disagree with me, because it is those disagreements that help me as well as others understand the nuances and the potential limitations of what we believe. We're in an era where misinformation, as has already been referenced, is all around us. And it's only through respectful disagreement in the workplace and in others that we actually uncover new and different ways that we're thinking of.
Thank you for that. Looks like we'll have time to go around again, but I want to make sure we recognize the people who have indicated they have additional questions by raising their hand. So let's go to Representative Javner.
Thank you, Senator Claxton. Can I ask a logistical question first? If we're not able to ask all the questions that we have and the questions that we sent to you, will those be answered and in a reply emailed back to us?
Molly Belgard and I will endeavor. We've certainly reviewed some of those questions. I can't promise that we'll be able to answer every single one of them.
Okay.
That said, you can ask 2 questions because you asked one the first time, so you get a dispensation.
Well, thank you very much. I appreciate that. So this one is, okay, so we're 2 years into the pandemic. So can you just give us a little bit of data behind what we now know of natural immunity, and / with that, what is the, comparing that with what the efficacy of the vaccine is at this point of what we know?
Sure, and I thank you, Representative Javner. I did recall seeing that question, and just to be clear, we will endeavor to, but our staff are working more hours than I care to reveal. So I want to make sure I try to balance demands on their time, given all the capacities of what they're undertaking. With respect to natural immunity, or what infectious disease experts refer to as virally derived immunity, it's a thing. It's certainly a phenomenon. That is what bodies do after having been infected, if they survive. If they don't survive, then there's no reason to discuss it. And that's one of the drawbacks of relying upon an approach that predicates the next encounter with the disease on whether you survive the first encounter. What we've learned more recently, particularly with respect to Omicron, earlier I referenced some scientific differences with Omicron as it relates to contagiousness and transmission. One that I did not mention is differences as it relates to immune system evasion. Unfortunately, there are some data that Omicron, as well as Delta before it, were able to glide by the body's immune defenses more easily from the natural immunity perspective than the vaccine-derived immunity. The differences in the magnitude of these effects were sufficiently compelling for me and vaccine and infectious disease experts to recommend that even for somebody who received or got COVID, it's still wise to take the vaccine rather than relying solely upon their body's built-in immunity in the event that they were to encounter the virus again. Indeed, data from a couple of different places now suggest that hybrid immunity, vaccine plus virus, is really the best you can get out there. Given the what we know about the safety of the vaccines, I don't think there's any reason for anyone who's gotten COVID not to get vaccinated.
Okay, Senator Claxton, one more.
Please.
Thank you. So can you give us an update on how the National Guard troops, and we just saw that more were going to be, engaged this week as well. How have they helped alleviate the pressure on our sorely understaffed medical facilities?
Yes, thank you for that question. Now, first of all, I don't know how I can say this other than to say we would not be in the position we are in the pandemic, which is to say in a tough spot, but able to talk about vaccination rates and increasing testing, were it not for the partnership and the men and women of the National Guard. This is a group of men and women who on Tuesday, when most of us were huddled up inside because of the freezing weather, were outside at the armory directing traffic to help people come inside and get vaccinated. Their service to the state cannot be understated. And on a personal level, I'm so appreciative for their partnership. Representative, we have throughout the pandemic utilized the National Guard. For example, just here at the Maine CDC, they are working with us to deliver PPE. They are working at our laboratory, getting samples in and getting them ready for testing. They're working within our building, assisting with various different tasks. That's been throughout the pandemic. More recently, as healthcare facilities have been under greater stress, we've deployed them on a more regular basis. I speak with healthcare facilities very frequently, and the response to having the men and women of the Guard deployed there to help with sanitation and environmental concerns, to help keep patients safe, to help pass food, to help with everyday tasks at the hospital, hospitals have been exceedingly thankful. The presence of the National Guard in those healthcare facilities allows their clinical staff to be freed up to focus on clinical matters, while the men and women of the Guard can work on and address non-clinical tasks. This has been really instrumental in helping what we call somewhat technically decompressing hospitals, allowing hospitals to then move patients to longer care, post-acute care, which then frees them up to take care of new patients coming in.
Thank you.
Senator Moore.
Thank you, Mr. Chair. Dr. Shaw, something that's been kind of bothering me a little bit, I guess, is that, as I hear about the numbers of people that are using the self-tests or the at-home tests, how many of those positive tests or positive results are even being reported? So are we understating how many positive tests we have in the state of Maine because of that?
Thanks for that question, Senator. In every single epidemic, outbreak, and pandemic that has ever occurred, no public health authority has 100% insight into every single case. Indeed, I was just sharing with my team this morning about experience I had working on a malaria outbreak a long time ago in another part of the world. And one of the challenges is, have we done enough testing? Do we really know what's going on? And there are models that help us understand that. But fundamentally, as we think about management of a pandemic or an outbreak, it's always a balancing act. Always. Everything is a balance. And when it comes to home tests, some of those results are reported because COVID-19 remains a notifiable condition if you're a healthcare provider. So if you go to your doctor's office and they in the office administer a Binax now because you're not feeling well, and it turns positive, well, that's a case. And that healthcare provider has an obligation under our regulations to report that to us. But we know that may not occur elsewhere. There are folks out there who buy the Binax now, use it when they're feeling sick, and test positive. They are not required, nor do they report that to the state. That's okay. Again, it's a trade-off. We're balancing rapid access of a rapid test with maybe not knowing every single case out there. This really speaks more broadly to what are the metrics that tell us what's going on in the pandemic. And increasingly, it is less and less about new daily cases, and increasingly more and more about things like hospitalizations, ventilator use, medication use, going back to Representative Zager's question. Those are increasingly the metrics that matter, less and less daily new cases.
So Representative Lemelin, do you have a question?
Yes. Real quick, I just want to make a comment on Dr. Shaw. On the 671 deaths, you said there were placebos done. And Dr. Scott Atlas, who worked with Dr. Fauci and Dr. Birx, he wrote a book and he testified that no placebo tests have ever been done on the vaccine to date. So I just wanted to make that comment that it seems that he disagrees. But here's my concern. My concern is
Representative, he doesn't disagree. He's wrong.
Well, okay. That's doubtful. He's one of the top
radiologists in the country.
Okay, whatever you say. Let's go to the testing. My concern is this. I just had an operation, and before the operation, I was told that I had to be tested within 72 hours for COVID, unless I can prove that I have a vaccine. So, of course, I started to ask questions because this didn't pass the sniff test for me. When I asked the questions, of course, I was hung up on because they don't want to answer any questions, I guess. Then finally, one of the supervisors for surgery called me back, and I asked him, if I am tested 72 hours prior to my operation and I test negative, but yet the next day I come down with COVID, you're still going to operate on me? He said, yes. And I said, if I'm fully vaccinated and I have COVID, you're still going to operate on me? He said, yes. I said, then why would you force me to travel a half an hour to be tested? Or why would you ask me if I'm vaccinated? It serves absolutely no purpose. And with that, see, my concern is the testing. And I've told you this before. I think the only reasons we have extraordinary numbers is because we are testing absolutely everybody in the entire state. Back in 2018 and 19, of course, we had, according to your website, 10,320 cases of the virus before COVID-19. We had 880 hospitalizations and 34 deaths. These are staggering numbers. We didn't do any of the things that we're doing today, none of them. And we tested nobody and had 11,000 cases nearly. Can you imagine if we would have tested absolutely everybody in the state? You reported that we've had 75,000 cases a year. I'm willing to bet, and yes, I know you're going to say we don't really know this, but I'm willing to bet that if we tested everybody in the state, those numbers would be pretty high, maybe even close to the 75,000. So I'm not sure why we're doing all the testing, because if the testing stopped, the fear would stop and we wouldn't have these staggering numbers. So
Representative, as you would imagine, I do disagree with you here. You're right. If we were to stop testing, the numbers would stop, but the deaths would continue.
Yes, sir, but they're going to continue whether you test or don't test, the deaths are going to continue. But back, if you could answer my first question, and that is, why do you have the hospitals? And if you're not doing it, why are the hospitals, through either your suggestion or HHS, why are they demanding this testing before operations, or asking if they're vaccinated, if they're going to operate whether I have COVID or not? To me, it doesn't serve a purpose, and it's a waste of my time.
I disagree. And I think, first of all, it's not a Maine CDC requirement that a hospital or preoperative patient be tested on any time schedule. That's a decision left to individual hospitals and indeed individual medical providers. I think there are two ways that I would look at this scenario. The first is fundamentally, this is about risk reduction. Right? We are not in a world where the risk of anything can be eliminated, no matter what it is. The question is, are there prudent steps that we can take to reduce that risk? You're right, Representative. You could go get that nasal swab right before a procedure, get your swab, send it into the lab, and you could be exposed walking out of that drugstore. You're absolutely right. That is a possibility. But the question is, in the main, what gives us the best glimpse into whether somebody, before they go on the operating table, has COVID-19 or not? For an anesthesiologist, for example, knowing whether the patient they are about to operate on has COVID-19 may significantly affect the manner in which they adjust blood gases, or the volume of anesthesia, or the way in which they care for a patient coming out of anesthesia. Knowing that fact could be the difference between how an anesthesiologist makes a critical decision. The other way that I think I look at this is that it's also a matter of, again, calibrating the risk of the procedure versus the risk of going in with COVID. For a life-threatening procedure, you're right. Almost certainly the surgeon is going to go ahead and operate, and the anesthesiologist would agree. But for a purely elective procedure, the incremental risk of operating on someone with COVID may not be worth it in that moment, and it may be better to delay the procedure. These are highly personalized decisions that we trust healthcare providers to make. I suppose my view of this is that if we trust healthcare providers to put us into anesthesia, to cut open our bodies, replace our joints, transplant our organs, why wouldn't we trust them when it comes to their protocols for when they should be testing patients for COVID?
Representative Connor.
I, of course, disagree with you, but I thank you for your answer.
Thank you.
Representative Connor, you have a question.
Yes, sir. Thank you, Mr. Chair. Dr. Shah, just going back very quickly to Representative Javner's remark about the National Guard being called up. I'm hoping you can clarify for me, and I don't know if you can, but I want to make sure that we're not robbing Peter to pay Paul. I know Representative Zager and I both have military experience, and most National Guardsmen, they work in the field that they're specialized in. So are we pulling them from other healthcare facilities to work in new healthcare facilities? If you could just explain that.
I absolutely could, Representative Connor. That's a critical question. I'm glad you raised it. Now, we've been very mindful to not add by subtracting. You're absolutely right. By taking a nurse or a phlebotomist from hospital A, who happens to be a Guard member, and moving them to hospital B, we haven't improved the system overall, because our goal here is not necessarily one particular floor, unit, or even hospital. It's the system. So we've been very mindful. In Maine, as you're likely aware, sir, there is not a medical unit, as there are in other states. And so thus, when we've worked with the National Guard to deploy members, we're mindful of what their background is. And in some cases, we've been able to maximize their background. In other cases, and in fact, I'd Well, I don't want to know. I don't know if it's the majority. I don't want to misspeak, but we've been very mindful not to commit the error that you noted there.
Thank you very much. I appreciate you clarifying that.
Representative Meyer?
Thank you, Mr. Chair. Dr. Shaw, two quick questions. Wastewater testing in Eastern Massachusetts suggests that Omicron is on the decline. So just a quick overview of how we might be using those kind of measurements here in Maine, and what your thoughts are on what that impact of that kind of testing is on where we are going forward.
Yep. Thanks for that question, Representative Meyer. First, in the lead into your question, keyword is suggests. I'm encouraged by the results that came out from Boston on Tuesday night. They are a good piece of a story, but I hope that story materializes. That's really the bottom line there. It's too early to tell. So suggest is the key word. That being said, I'm a fan of using wastewater testing. It has shown itself to be a fairly accurate predictor of what might happen in a community. That being said, there are two questions that we just have to grapple with when it comes to wastewater testing. The first is, right now, much of it is being done at the municipal level. And that leads to, if I may just be direct, that leads to a so what question. Great, you've detected a spike in a community. And then what? What are the public health interventions that we could conceivably take to act upon that data? If it's purely for informative purposes, that's great. There's value there. Don't get me wrong. But, and then this is the next observation I have with wastewater testing. My view is that we should couple the potential predictive value of wastewater testing with actionable locations. That is to say, our team has been working with two different types of groups, colleges and universities, to try to get dormitory level testing online. And then going back to our partnership with the Department of Corrections, trying to work on it with the Department of Corrections. Because in those situations, there are actionable public health steps that we can take, deploying testing, so on and so forth, looking out for symptoms, things of that nature. So I'm a fan of wastewater testing. The question is, how do we use it best?
Thank you. Mr. Chair, just one more quick question here, please.
Please.
Just in general, the lessons learned from the reestablishment of the large volume center like the Armory.
Yes, well, thank you. And first, I said this earlier, but I just have to offer a public and profound thanks to our partners who made that site happen. It was, in addition to the Maine CDC, it was the Maine National Guard and Maine Emergency Management, to say nothing of so many partners here in Augusta Police, the City of Augusta. They all made it happen, and it's been successful. We are close to administering the 10,000th dose of COVID-19 vaccine at that facility, and now, of course, we're doing testing and we're scaling that testing up. So it's been successful. It came in at a time when there was a clear need. I don't know how long that facility will be online, but we stood it up at a time when, frankly, some commercial pharmacies in Maine were not able to meet the demand, and I'm glad that we did. Indeed, our team went from concept to action within 96 hours. And that is a testament to the team here at Maine CDC. The lessons learned are I think, for me, twofold. There's an adage in emergency management, which is everything you do before an emergency hits is considered to be premature. And everything you do after an emergency hits is considered to be too little and too late. And that holds true with respect to the Armory. Do I wish that we had seen the signs that there was going to be this unmet need for COVID vaccine, boosters in particular? Do I wish we had seen them earlier and had been able to set up the Armory 2, 3, 4, 5 days in advance? I do. But at the same time, when we opened that site, there was a line out the door. So for me, the principal lesson learned is, how can we be more responsive earlier in the course of something rather than on day 3 or 4? That for me is what I want to talk about more with my team.
I'll ask my question and then we'll go to Representative Connor. Is it a fair summary? I'm always looking for ways to help constituents and people who I talk with understand where things stand with this pandemic. Is it fair to say that at the current time, 77% of Mainers, those vaccinated, are accounting for 30% of the hospitalizations and 20% of the ICU or the ventilators, and that the 23% who are unvaccinated are accounting for 70%.
Yes, Senator, those are fair statements with one potential modification, just going into the weeds a little bit. At certain times in recent weeks, according to hospitals in Maine, at certain times, from time to time, 100% of the people in the two largest hospitals in Maine who have been on ventilators, at certain times, 100% were unvaccinated. Think about that. At certain times in recent months, every single person with COVID-19 who was on a ventilator was someone who was not vaccinated. So yes, but your framing of that is correct. Right now in Maine, the minority of individuals, the unvaccinated individuals, account for the majority of hospitalizations.
And now my last question is about how are we doing with any testing backlog and adequate staffing in the state lab for handling PCR?
The state laboratory, even though on Tuesday they received over 2,200 specimens in one day, they have stayed on top of it. They have moved staff. Of course, they are supported by the National Guard, which has been critical, but they've moved staff around to throw as many people at making sure that when a test comes in, the result is reported out in approximately 24 hours. Sometimes that's our standard, is to attempt a 24-hour turnaround time. Sometimes it goes a couple of hours beyond that. Usually it's underneath that. But what we try to benchmark ourselves on is a 24-hour turnaround time. And we've been, and even notwithstanding the significant increase, we've been able to meet that.
Thank you for that. Representative Connor.
Thank you, Mr. Chair. Dr. Shaw, much to your delight, I'll move on from COVID. You had mentioned that some of the other things that the department is taking on is the forever chemicals. So I just wanted to touch base really quick about the articles and some of the things that we've been hearing about the deer population in Maine with the forever chemicals. I didn't hear too much about it in the news. It kind of was just glossed over, in my opinion. So I'd just like to get a little bit of information from you, if you could give us a current update on what's going on with that and what the department is doing to look into that.
Well, thank you. A lot of our focus right now, or at least in recent months, has been in and around the Fairfield area, where the deer advisory was most active, and that follows recent findings in other commercial products or farm products, milk, et cetera, and then of course the water itself. We are expanding our purview now beyond Fairfield, having done a wide amount of sampling there, working in close partnership with the DEP. I've been meeting with the team with our environmental health team to understand or plan out, and not to be brusque about it, but what's our goal here? What are we doing? Right now, it's a fair amount of surveillance. We are trying to look for other Fairfields. What else is out there that we need to identify such that we can undertake the same set of deep dives, water, milk products, farm products, agricultural, forestry, et cetera. So that's one element of our work right now. Another is, just to go back to the exchange that I had with Representative Lemlin, looking to see testing. We need to be able to conduct more testing around the state to try to get a better handle on where things are. The other element of our work is of course, remediation. What do we do if and when facilities, groundwater, et cetera, are found to have high levels of these chemicals in them? In some cases, as with deer, it's a do not eat or do not recommend to be eaten order. In other situations, it entails working with the homeowner or the business to install, frankly, what are relatively, becoming more common filtration systems to make sure that those homesteads, those houses are not just rendered unusable because of these chemicals. This is going to be an issue that's going to be with us for a long time. Every time we dig into PFAS, we find more about the topic scientifically, to say nothing of just actually finding more of it. So PFAS are not only are the chemicals labeled forever chemicals, the nature of this problem is going to be a long-standing one.
Thank you for that. I appreciate it.
Anybody else who has questions before we go to Senator Moore, please put up your hand. Senator Moore, your turn.
Thank you, Senator Claxton. Dr. Shaw, this is just a question that came from one of my colleagues, and it's related to the PCR test itself. What is the cycle threshold that we are currently using in the lab when we're testing the samples?
We have throughout the pandemic, because we utilize a test from IDEX, the FDA specifies a cycle threshold of 45.
45, okay, good. Thank you.
Before we go to Representative Lemelin, I want to make sure that everybody's had a chance to ask their question or their second go round. Representative Lemelin, do you have a succinct question in the remaining 8 minutes?
No, just a quick comment. It's a positive one, Dr. Shaw. I just want to let you know that I agree with you 100% that we need more testing for PFAS throughout the state. And I'm wondering if, I guess I do have a question. Is there a way to make testing more easily for individual people and more affordable? Because I have quite a few constituents and friends throughout the state that have a huge concern, but the question is, A, can they afford it? And B, how can we get it more easily accessible?
Thank you for that question. You and I agree here. The challenge is around the affordability piece. The testing is out there. There are commercial laboratories that do offer the testing, but what we've seen is that it's pricey. I don't mean to suggest that there's something nefarious, but I've been briefed by our laboratory team that testing for these chemicals is exceedingly difficult. First of all, there are thousands or hundreds of them out there. And so which ones are we to test for? Because manufacturers alter different molecules over the year, resulting in literally hundreds of these. And so right off the bat, there's not just one we're looking for, it's an entire family of chemicals. Second, because of the way that the chemical is structured, the testing is I'm told, very technical, very difficult. So for us, Representative, it is really about the affordability, because the labs are out there. Now, I'm not sure, and then the last piece, it's also unclear to me what the capacity of these various laboratories is to handle more. I mean, if we're really serious about getting a better handle on the nature of this problem in the United States as a whole, certainly laboratories are going to be needed to increase. Laboratories will need to increase the volume of water or milk samples that they can handle. We're getting into it with laboratories as well as with our own laboratory staff. No easy answers, no announcements, but I concur with you. This is going to be a challenge, both on the affordability as well as the availability point.
Thank you. Just real quick though, I thought in Maine, even though there are a vast number of different PFAS issues, I thought in Maine, we were restricted to a few very serious ones. Is that not correct?
Representative, I want to make sure I answer your question. Do you mean just sort of, when you talk about issues, you mean sort of milk, deer, or
no,
or you mean
I'm
the
talking
chemicals
about the
themselves?
different types of PFAS. You said there's such a variety of PFAS that it's hard to test. And I agree with you, but I thought in Maine we didn't have that issue.
Sir, I'm not sure about the answer to your question, but I'll check with our lead toxicologist and get an answer on how diverse the chemical set is here in Maine.
Thank you.
I think our intervention last year was to recognize 6 as being of primary concern and setting a threshold for them. We didn't pay attention to the other 1,500 because there wasn't enough data yet.
Yep.
Representative Meyer.
I unraised my hand, Senator. I know we've got a hard stop, and it looks like we've got 4 minutes, and I'm not sure if Dr. Shaw can answer this question in 4 minutes, but I will ask it anyway. About 2 years ago, my predecessor in this role, Representative Hymanson, asked you a question that I would like to pose once again. It may not be quite as easy to answer this question in light of what's gone on the last couple of years, but what's keeping you up at night?
Oh, man. Well, there's this virus here in Maine that's really keeping me up at night right now. 2 years ago, the virus was not here in Maine, but I suspect you knew that element of my response. So I'd say right now, Representative Meyer, there are two things that are keeping me up. The first is, or a couple, but in no particular order, hospitals and our healthcare system. I am concerned, and one of my I'd say my primary goal with respect to COVID right now, from a strategic perspective, is trying to keep center from falling out from the healthcare system, and hence the questions about the National Guard and what we're doing there. Second is keeping kids in school. I don't need to tell this group, and being in school, being in the classroom matters. It's where kids learn. It's where they eat. It's where they learn to socialize. Keeping kids in the classroom is a goal for the entire administration. How we do those things is one thing keeping me up at night. Another is things that are coming at us, and the two that are truthfully keeping me up at night are the looming mental health and substance use crisis. We all know it's out there. We all hear about it, but as COVID perhaps theoretically subsides, that issue will then take prominence. Are we ready for that? Related to that is, I don't know that this is keeping me up at night, but I'm thinking a lot about it. What does COVID look like in the future? It's not going away, right? So you've heard me mention, for example, the metrics that we use to understand it, moving away from daily cases and daily positivity rates. Because I do concur with Representative Lemelin here that to some extent, not to the extent that he probably believes, but to some extent, those daily cases, those daily changes are causing some degree of stress. I've seen it in some of my own family members, and they are leading folks to get a misunderstanding of the nature of the pandemic. Oh, there were 1,600 cases today, so I better stay inside. No, that's not right. How do we adapt to the next phases of the virus? What does that mean? What does that look like? What does it mean operationally? What does it mean from a communications perspective? And then the final thing that's keeping me up at night is, where does the Maine CDC go from here, right? What are we gonna work on next? That's what I have been talking with my staff on. It's not one thing, it's a slate of things. What are those gonna be? Are we gonna get back to addressing childhood lead poisoning with greater prominence, things of that nature? These are all topics that I look forward to working with everyone on.
Thank you, Dr. Shaw. That brings us to 12 o'clock. Representative Connor, do you really need to ask a question? I mean, could you like to ask a question?
Very quickly, I'm so sorry, but Representative Meyer just segued perfectly. And I just really quick, Dr. Shaw, does the Maine CDC have a definition, or do they have a definitive term of when pandemic ends and we move into the next phase?
The two hardest times in an outbreak or a pandemic are the beginning of the pandemic and the end of the pandemic. And you never know when to call it a pandemic, and you never know when to say it's over. These are decisions that are largely made by federal health partners. But we're heading in that direction. Right? We're definitely heading in that direction. Notwithstanding the fact, let's not forget that we are still in the midst of a major peak. I'm not saying we're throwing in the towel, but we can do two things at once, right? We're skilled professionals. We can handle the peak that is in front of us and simultaneously plan for the future.
Thank you. Thank you for that, Dr. Shaw. And thank you again for spending the time with the committee, answering a lot of questions that are important to us, to our constituents, to our families, and to the state. So thank you for your attempts to address those issues and concerns. We very much appreciate you taking the time.
Thank you all for the great questions and lively discussion. I look forward to being back with you all again soon.
And that brings us to 12 o'clock, a little just after. And our next scheduled assignment is to meet at 1 to hear from Gordon Smith and Dr. Jessica Pollard. So I'll entertain a motion to adjourn till 1 o'clock. I'll remind everybody to turn off their video and their audio as they step away, and we'll see everybody at 1. Is there a motion?
So moved.
And a
Second.
second. All those in favor, we can do this by show of hands. Very good. Thank you. See you at 1. Hope you feel better, Representative Connor.
Hi there, Senator.
Hi there. Mr. Smith, how are you?
Doctors, nurses. Yeah.
So we're live. So
all right, I'll shut up.
No, that's not what I was implying. I just meant clean it up.
Yeah.
I think there's a
Ed-
doctors and nurses and lawyers, oh my, kind of.
Yes, yes. Well, it's nice to see you all.
Welcome, Dr. Pollard.
Thank you.
Yet another doctor of a different kind.
So it being 1 o'clock, and it looks like most of us are back from lunch, except for those who couldn't join us today. So I think since there may be a new group of people joining us for this afternoon session that might have listened in the morning, we'll just go around and introduce ourselves again. Let's start with Representative Zager.
Thank you, Mr. Chair. Good afternoon, everyone. And my name is Sam Zager, representing District 41 in Portland.
Representative Lemlin.
Thank you, Senator. Good afternoon. My name is Michael Lemlin. I represent House District 88, Chelsea, Jefferson, Whitefield, and half of Noblesboro.
And Representative Stover, I saw. When you're
Good
on mute.
afternoon. My name is Holly Stover. I represent the towns of Boothbay Harbor, Southport, Edgecombe, Westport Island, and part of South Bristol.
Thank you, Senator Baldacci.
Joe Baldacci, I represent the city of Bangor and the town of Herman. Thank you.
Representative Perry.
Ann Perry, I represent House District 140, which includes the communities of Indian Township, Baileyville, Barron, Calais, Charlotte, Robinson, Perry, Pembroke, and Pleasant Point.
Representative Craven.
Thank you, Mr. Chair. Good afternoon. I'm Margaret Craven, and I represent House District 59, which is part of Lewiston.
Representative Madigan, welcome.
Thank you. Thank you, Mr. Chair. My name is Colleen Madigan. I represent House District 110, which is half of Waterville and a little bit of Oakland.
Representative Griffin.
Good afternoon. My name is Abigail Griffin. I represent House District 102, which is Glenburn, Levant, and Kenduskeag.
And Senator Moore.
Good afternoon. My name is Mary Ann Moore, and I represent Senate District 6, which is all of Washington County, as well as Goldsboro, Winter Harbor, and Sullivan in Hancock County as well.
Representative Meyer.
Thank you, Mr. Chair. I am Representative Michelle Meyer, serving Southern Maine's House District 2, which is Elliott and parts of Kittery and South Berwick.
And I'm Ned Claxton, representing Senate District 20, which consists of Auburn, Minot, Mechanic Falls, Poland, and New Gloucester. We also want to introduce the people that make the committee run. So we'll start with you, Sam Seneff.
Sam Seneff, and I am a legislative analyst with the Office of Policy and Legal Analysis.
And Anna Brum.
Hi, I'm Anna Broom, and I'm the other one.
And Karen Thomas is with us to help keep us all organized.
Yes, I'm Karen Thomas, and I am the clerk for the Health and Human Services Committee. If you need assistance today, please email me, hhs@legislature.maine.gov.
And I think we'll skip some of the traditional introductory remarks, other than to say that there might well be some technical glitches. We try and do that on a regular basis. But we have guests with us this afternoon, Gordon Smith and Dr. Jessica Pollard. And I see Geraldine Betts has joined us too. So have you all worked out? Gordon, are you to start?
Yes, Senator. In fact, I am. Well, Senator Claxton and Representative Meyer and members of the committee, I'm Gordon Smith, the state's Director of Opioid Response. I'm in a beautiful suite over in the Cross Office building, so I have a split screen, and I apologize for that. But I want to speak into the laptop that's got the microphone in it. It's a real pleasure always to be before your committee. Today actually marks my 45th year working with the legislature, and I get just as excited about it as I did 45 years ago. 2 of those sessions have been remote, and 43 of those years were in person, and I much prefer the latter, and I'm sure you do as well. But being what it is, we're happy to be with you today remotely. Dr. Pollard is going to take you through the PowerPoint slides that we've prepared to be responsive to your questions regarding the options program, overdoses. There's also a slide on the prevention and treatment fund, but I also have shared with your staff a document I prepared that more thoroughly takes you through that, and I'll close my opening remarks with references to that document. So I'm going to talk for perhaps 8 to 10 minutes, and then turn it over to Dr. Pollard to do the heavy lifting, because the options program is run out of the Office of Behavioral Health. Thought it was more appropriate for her to do the details on that work. I want to just start by acknowledging that it's been difficult to manage this epidemic within the global pandemic. We've talked about that before. And we did not have a great year in 2021, depending upon what you choose to measure. We are very transparent in the number of overdoses, both fatal and non-fatal. And we're comfortable with sharing the data, even though the fatalities are suspected overdoses until they're confirmed by a national lab that does work for the Office of the Chief Medical Examiner. But the Attorney General, who I know you'll be with next week, is comfortable, and Dr. Sorg, who you're going to have on Tuesday, they're comfortable with us sharing this data, because there's not a lot of differential variation once we get those reports back. So if we send 100 reports to that lab of suspected fatalities, probably 97, 98, 99 of them are going to be confirmed. So we just think it's more important that the public and all of you know more in real time what's happening, and not wait months and months and months, because now all these labs are backed up. Work shortages, COVID, all the usual. So we did have about 635 fatalities last year. That's a 23% increase from the year before. Of course, it's disappointing, but we're going to talk today about all the things we're doing to try to do better and try to keep people alive. It's also equally important to realize that nearly 10,000 people survived an overdose. For instance, as of the end of November, there were 578 fatalities, but there were 8,619 reversals, they're not all exactly reversals with Narcan, although most of them are, because there are some people who may just get chest compressions or rescue breathing. They may not have been serious enough overdose to be fatal. But I want to acknowledge that for every person that dies, and we mourn every single one of those losses, there are probably 15 people who survive. And that's where the options program comes in. It's the behavioral health liaison's responsibility to try to reach out to these individuals and connect them with services, either more harm reduction services, ways to use more safely and keep them alive, for the hope of someday deciding that they'd like to get into recovery and want treatment, and or link them directly to treatment. And Dr. Pollard has the statistics on the first year of the program, which are very encouraging in terms of the connections that they're making, the referrals that they're making. And this was just, we really didn't have a full complement of all 16 liaisons until very late in the year. So it's encouraging. What has led to the increase in the fatalities? Well, it's a combination of things, but this is mostly an epidemic of fentanyl. 50 times more powerful than and 50 than hydrocodone, and 50 to 100 times more powerful than heroin, and it's in everything. The data shows that the percentage of cases directly linked to fentanyl of deaths went from 67% in 2020 to 77% in 2021. So it is really in everything. And the other part of the options campaign, the media campaign and the social media campaign is delivering those messages to be careful. Fentanyl is in everything. It just a 1 grain, something as small as 1 grain of salt could be in whatever it's being mixed with, could be fatal. So it's mostly about fentanyl. It's also the international drug supply, in that we don't have much ability to control that. And it's also about the pandemic, that there are fewer services available, the healthcare workforce shortages. We've had times when we didn't have even the few detox beds that we usually have. Even today, for instance, the major facility we have in Portland at Milestone, they would normally have 16 beds available, and they only have 6 beds available because of COVID and because of staffing shortages. So it's not a surprise that this perfect storm of COVID and fentanyl and isolation, change, stress, the mental health piece. I was able to listen to Dr. Shah this morning in his presentation to you, and I was really pleased at the end when you asked what keeps him up at night, and one of those items was the mental health crisis and the crisis and substance disorders, because that keeps me up at night as well. We do pretty much, we expect that when the national figures are released, when other states report their experience in 2021, we'll probably be about in the middle. Our experience will probably pretty much mirror the national experience. You saw the horrific numbers released a few months ago that 100,000 people are dying every 12 months across this country. And with the majority of that due to opioids and the vast majority of it due to fentanyl. There are other things to worry about, including fentanyl being pressed into fake pills. And we have a campaign that says one pill can kill. And we haven't seen much of that in Maine, but we're very concerned about it. I think knowing that Dr. Pollard also is going to talk about what our priorities are for 2022 and where we kind of finished up 2021 with a number of our initiatives. And hopefully we'll have some time for questions at the end, that I'm now going to pivot to the Prevention and Treatment Fund. Just talk about it very briefly. I want to acknowledge that these funds come to us through the Bureau, through the Board of Pharmacy, where well over 20 now manufacturers of opioids pay an increased assessment and a product registration fee in some cases. And the Board of Pharmacy, this has not been an easy task that the legislature gave them in that legislation back in 2020. They're not used to collecting fees of $55,000 or $250,000. And Jerry Betts and her team over there have done just an incredibly great job. And it was it's difficult, and it remains difficult because they want to confirm, of course, whether or not, we don't want to rely completely upon an opioid manufacturer telling us whether they've met the threshold, for instance, of 2 million pills, which puts them into the $250,000 product registration category. And so they look at the prescription monitoring program. Barry looks at these ARCOS reports that come in from the manufacturers that were also part of this legislation. So again, I just want you to know that we appreciate what the Board of Pharmacy has done and their staff. It produced about about $2.3 million in the first year, and we expect something similar this year and maybe more. What I gave you in the handout that I hope might be in front of you, or well, it's not going to be in front of you, I guess, but in any case, I went through the 10 items on how the money was spent. That is primarily what you're probably interested in. It has to be spent all on opioids, all on prevention and treatment, but a pretty broad definition of that. The spending is done by the Department of Human Services. Commissioner Lambrou has the last word on it, but there were 10 different initiatives that were kind of spread between harm reduction, prevention, treatment, recovery support. And I remind you that that's all tied into our continuing updated strategic plan, that we have these 4 pillars of primary prevention, treatment, harm reduction, particularly naloxone distribution, as well as the syringe exchange programs, and the recovery support, recovery centers, recovery coaching, recovery residences, recovery-friendly work sites, recovery-ready communities, all of that. So again, it's really the harm reduction things that we're doing to try to keep people alive. We've distributed 136,000 doses of Narcan. We're seeing more and more bystander reversals, and that's why we're keeping 15 people alive for every person that we lose. So again, I hope you'll have some questions. I think you'll be very interested in those 10 spending categories. And And I hope within a couple of weeks, we can share with you what we intend to spend and have available in this particular fund in 2022. But do bear in mind that you're only seeing a small piece. This is really a modest part of our opioid response, because we'll have money from the settlement. We have expanded broad block grants in the substance use disorder area from APA. We've got private philanthropy. We have some money in the budget. And finally, the vast majority of the money that is being dedicated to this issue comes from the federal government in the way of grants and block grants through the Office of Behavioral Health. So, but still, this is new money, a couple $1 million. I think we're doing good things with it. And with that, Senator, I'm going to ask Dr. Pollard to present before you ask me any questions. And again, I can't tell you how much I appreciate your interest in the issue, your partnerships with us, and I appreciate very much Dr. Pollard and her work and the work of her team at the Office of Behavioral Health. So, Dr. Pollard, the floor is yours.
I think Senator Claxton needs to officially give me the floor. I'm not sure. There are probably rules here. But thank you.
Informational session. We'll make it up as we go along. You're
I
welcome
see.
to the floor.
Oh, thank you. And Gordon can say all these things off the top of his head. I like to stick to slides mostly so I don't ramble or go off on too much of a tangent. And it looks like we covered a number of these, so I will skip ahead over some of the slides. But if there are those of you among us like me who are visual folks, you might enjoy or appreciate seeing these as bulleted points as well. So Gordon already gave you the layout of what we plan to cover in response to your requests. And these are just the figures that I think Dr. Sorg will provide you more detail at a future session, but these are the takeaway points that Gordon has already outlined. And so just to add a little bit of detail about what we've done in response, I think a lot of this has been covered, but we are very assertively distributing naloxone, including through the options liaisons, which I'll talk a little bit more about. And then a really important layer to this is the public information campaign, both targeting the population of Maine as a whole, but also specifically individuals who are using substances through more specific messaging to individuals who are using substances. So different types of messaging depending on the intended audience. So this isn't an exhaustive list, but just to give you a sense of some of the public health messaging, we have our now public-facing spike alerts that anyone can sign up for so that they receive notification when there have been a number of fatal or non-fatal overdoses within a 24-hour time period. That triggers an alert. The Maine Drug Data Hub, which gives transparency into the different data sets that I'll speak a little bit about today, but including naloxone distribution, fatal and non-fatal overdoses, and other important metrics. The options campaign, which I'll spend a little bit of time on and give you some sample campaign materials. And then more recently, we launched the Get Maine Naloxone website, which gives people more information about how to actually get naloxone and make sure that they have it on hand. To hit upon a few milestones, as Gordon already mentioned, we're over 130,000 doses of naloxone distributed, more recovery coaches out into the community helping individuals, the residents of DOC who we've treated with MOUD and through the county jails is substantial. And as the committee is likely aware, the substantial rate increases in a few areas related to SUD treatment, particularly as already implemented, the residential rates, which coincides nicely with the approval of the 1115 waiver to exceed 16 beds in facilities, which wasn't previously allowable. Senator Moore.
Yes, thank you, Dr. Pollard. What is MOUD?
Oh, I'm so sorry. I've tried to get out of the habit in speaking an acronym, but I fail often. So people used to exclusively use the term MAT for medication assisted treatment, but there's been a shift to saying MOUD, which means medication for opioid use disorder, recognizing that in itself that is a form of treatment. It's not simply an assistance to treatment. So it's making a distinction that the medication itself is an intervention. And we celebrate and look forward to ticking the number over 90,000, but since January of 2019, seeing significant increase in the number of individuals enrolled in main care expansion, I should say. We saw the opening of 2 new methadone clinics, or OTPs, last year, which is the first time we've seen new methadone clinics in over a decade. We continue to see increased access to, this time I did call it MAT, compared to 2020, a 4% increase, but compared to where we were way back in 2017, this is a 44% increase in the number of prescriptions for all of the medication forms other than methadone. So this does not include methadone. We have new certified recovery residences, which is an increase from where we were a few years ago. And importantly, not just that we have more residences, but that we have a greater proportion of residences that are welcoming of people who are receiving medication treatments. We have new syringe service programs, and this is a marker or milestone that an increase of over 1 million syringes exchanged or dispensed rather from the previous year. And we are now at 18, although Gordon may correct me on that because I think we keep seeing more come online, but as of last count, I think we're at 18 recovery community centers. Our colleagues in the Department of Education implemented a social and emotional learning curriculum and have a lot of engagement in that program, a lot of registered users. We were very pleased to see the enactment of legislation to allow naloxone leave-behinds for EMS, and that's supported by a $6 million grant for that effort. Distribution has begun for fentanyl test strips thanks to the passage of that law. And then we continue to get good community engagement and participation through showing recovery-focused movies that have been produced in Maine about Maine communities. Penobscot County and Androscoggin County, Gordon, are the 2 counties featured.
And Washington County.
Yes, so we and they're quite moving films. If you haven't already seen them, we can share those with you. The website I mentioned about data transparency, we are just under 19,000 people having access to the site in 2021. And our Get Maine Naloxone, which is a relatively new site, it's only been up about 4 months, over 1,100 people have accessed the site. And just toward the end of 2021, we started meeting as the overdose fatality review panel. So a lot happening so far, or last year in 2021. Looking ahead to this year, as we, I think, acknowledged in Gordon's remarks, the pandemic has also had a significant impact on people's mental well-being, and by all estimates is driving worsening behavioral health challenges in people who already were vulnerable, and new mental health challenges and substance use in people who maybe previously to the pandemic did not have those challenges, but the stressors have been significant. So we will continue our Strengthen Me program, which has served, I should have checked before I came on, but we are up in 60,000 encounters or sessions held for Maine people through that program. And the goal there is really to take more of a prevention approach to help people from getting to the point where they have an identifiable disorder. And we have a number of different initiatives that fall under that program, including those focused on people who are at higher risk occupations for the stressors related to COVID-19. Very pleased to be rolling out the Worker Bonus Initiative through the enhanced federal match under the Home and Community-Based Services Medicaid program. That is roughly $126 million that providers registered for at the end of 2021. And that the first payments are projected to go out in January or very soon. That will, that's along with a whole package of workforce initiatives. And when I stop talking, I'll put a link in the chat in case you haven't already seen it, for the department's recruitment and retention toolkit, which outlines a number of initiatives that we're working on to try to bolster. Sorry, someone is ringing my doorbell. I can ignore it, but excuse the interruption. So we're doing a number of things related to workforce. We could spend a whole meeting just talking about that, but I want to give you a sense that it's comprehensive in the sense that we're addressing pipeline issues, credentialing, any challenges to credentialing, flexibilities related to who can deliver services, including the department-sponsored legislation 1848 that I think we'll be talking about next week, and as well as the financial incentives to keep people in the field and supports of people to keep them in the field, including things like upward mobility. So there's a whole package there, and it's also things like immediate term solutions, the number of disaster spas that Maine Care has applied for to allow credential flexibilities as an immediate term example, and then short and longer term projects as well related to marketing and bringing people into the field. You're aware of the intensive outpatient rate increase that goes into effect at the beginning of this calendar year, the cost of living adjustments that will start in the upcoming fiscal year, and the supplemental payments during this calendar year. We are very pleased to be one of 20 states who received a CMS Mobile Crisis Planning Grant, which gives us the enhanced opportunity to reform that program and rate. I've been spending most of this week in a call of state mental health and state Medicaid directors with CMS and SAMHSA, going over the CMS guidelines for coverage of crisis services in line with SAMHSA best practices. And the CMS program explicitly requires SUD crisis as part of the new program, which will also come with enhanced federal match. We launched 988, a 3-digit behavioral health crisis number, in July. We hope that that will divert people away from law enforcement, away from the 911 and emergency department system. And as people are likely aware, calendar year 2022 is when we will complete the rest of the behavioral health studies, rate studies that haven't already recently seen a rate study. And a big goal is investment to increase the number of residential beds on the SUD side. We are coming very close to launching our Cumberland County Crisis Center. And that is that will include people who are in crisis related to substance use. We'll be launching and advertising to make sure there's good awareness of our real-time service locator tool that will give people much better information at their fingertips to know what's the right fit for treatment. There are screening tools that will be available to the public-facing side of the service locator tool, and real-time availability information so people aren't calling around trying to find an opening. They can see where there may be an opening in proximity to them. We have a number of enhancements on the PMP that you'll see when you receive our annual PMP report. We received a $1.6 million grant, which we'll use to further enhance the analytics of the PMP, but also the interventions that stem from the data for the PMP. So targeted academic detailing and more assertive outreach when we see problematic prescribing. We are very excited, and I'm giving myself credit that I did not put the acronym CCBHC and instead spelled out Certified Community Behavioral Clinic Model. We have the infrastructure in the department, the positions that we were fortunate to get in the last session to build that model, which will include integrated treatment for people with either mental health or substance use disorders or both, including elements that have 24/7 access and that have a certification component to ensure high quality of care, but also are reimbursed in a way that takes into consideration the things that are really important for service delivery. So a really, I think, valuable reimbursement model. And I'll try to pick up the pace a little bit since I think Gordon covered some of these elements. But we do also have new main care parenting programs and coverage for people who are working toward reunification who have substance use disorder as an eligibility criteria. So I think a lot of this is covered, and I really want to get into the options data. So people are aware maybe that the acronym stands for overdose prevention through intensive outreach, naloxone, and safety. It has both an on-the-grounds program component, our options liaisons in each of the 16 counties, as well as a public health campaign. So the goal of the options liaisons is really to co-respond when there is a call for an overdose, but also to follow up with individuals assertively after a non-fatal overdose, and to take referrals from really anywhere, and to do proactive work with individuals to try to link them to whatever resources the person is willing to accept at that time. So they may not be at a point where they're feeling that they can accept treatment, but maybe they'll engage in some harm reduction strategies, or they may be willing to participate in a recovery activity so they could be connected to their local recovery community center. And we work very hard to sign them up for Medicaid to make sure that they have coverage for treatment ongoing. Representative Craven.
Thank you. Could you, I'm sorry, I don't know what that is. But I need to know what the IOP rate increases, please.
What the percent is, or what the new figure is for the IOP?
Yes.
It's just shy of a doubling of the rate. If I can get that information to you before I leave you, I can pull that information up. I'd have to get out of my slides to get it, but it was somewhere just around $100, and now it's just shy of $200. But I want to give you the exact figures. It is a substantial increase.
Thank you.
Yes, that's the per day or per diem rate. But I will get you that exact figure. All right, Representative Stover.
Along the same lines, thank you, Dr. Pollard. Did you say that there were more rate studies to do? Because I know we've done a number of rate studies have been completed, and I'm just wondering, are there more rate studies planned to be done?
Yeah, maybe the most helpful thing to do, I will put the blog post that that Main Care put together that outlines the schedule of all of the to be enacted rate increases, and then gives a little summary of where we are with all of the comprehensive rate reforms. So we've identified calendar year 2022 for the behavioral health programs that haven't already had a rate study. So those will be kicking off soon with starting to engage the providers and getting the data and information necessary to reform those rates.
So the rate studies have been completed. You're just enacting now.
Sorry, no, some of the rate studies have been completed, but for ones that have not had a completed rate study, calendar year 2022 is when those rate studies will be conducted and finished.
Okay, thank you.
For the ones that haven't already just had one. Let's see. So I can pull up a different view that has, there are some increases since these data visualizations were last created, a couple more months worth of data. It's a little over 1,200 individuals who've been served by the program. And just to give you a sense of the distribution of the activities of the options liaisons, they're doing a lot of naloxone distribution, connecting people to different resources or referring them and helping make sure they follow up, and then responding to emergency calls and following up when someone has survived an overdose. And you can see that those are increasing over time in terms of the referrals and the types of programs that we're connecting people with. So treatment, recovery, harm reduction, and in particular, making sure we connect people to the Main Mom program. And just to give you a sense of the volume of naloxone distribution that happens via the options liaisons, it is significant. And we feel pretty good about this metric in terms of the success of the handoff of the options liaisons. So not just the referral, but was the referral actually successful? Did the person engage with the provider that they were referred to? And in 91% of the cases, yes, they did engage with the provider that they were referred to, which we're really pleased to see. Representative Madigan.
Thank you. I'm wondering if you have any information. I appreciate all these things on opiates. However, I'm wondering if you have any information, particularly about the options program and engagement with families or engaging with people with substances other than opiates.
Yeah, so any family members are also welcome to engage the options liaisons. I think I may have a slide that shows from where the referrals come from. So it's not just co-responding with law enforcement. It's also, we make publicly available information about how to contact your local options liaison. And while the focus of the program has been opiates, they're certainly willing to help people with any substance use disorder. So it's not meant to be exclusionary to other kinds of SUD challenges.
Do you have data as far as the amount that's been used for people with other
I
abusing?
do not. I'm not sure that we, I don't have it at my fingertips. We likely do have the somewhere, but I'll make sure. I don't think we necessarily collect diagnostic information because it's really just if somebody is identifying that they need the help, it's not, doesn't necessarily require a particular diagnosis to be made. So we may not collect that as we're not, as it's not a requirement to have an identified diagnosis, just an identification that you need help or support. Gordon, would you say it differently? Do you know if we have that, if we're collecting that data? Oh, you're on mute, Gordon.
Yeah, I am. I think probably we'll have to get back to Representative Madigan on that. You know, we don't split out different addictions. I mean, alcohol, frankly, it over the long term, it still kills more people than drugs. Nicotine kills more people than alcohol. So addiction is addiction, but we will think about what information we can get from the liaisons that would help us know. I mean, regrettable, you know, obviously when people die, we're able to break out those substances from at the lab, but not while we're working with them and getting them treatment. So we'll have to work on that, Representative Madigan.
Thank you.
Representative Perry, did you have a question?
Yes, I and actually along with Representative Madigan's question, really to get a sense of the types of substance use disorders that we have. I know we talk about opiates, but there's methamphetamine, there's benzodiazepines, which with the opioids tend to go with that as well. Do we have any idea of the level or the number of different substances that are abused or misused in the state?
Yeah, yes, we do. And you should ask Dr. Sorg about that on Tuesday, because she's the one that leads that effort. We're not testing as many of the substances as I'd like because of the cost of testing and because of the delay in testing. But Dr. Sorg's really the state's, if not one of the national experts on that. And she does have that data, Representative Perry.
I think there are different ways we can provide that information that, you know, as Gordon mentioned, there's the, among people who've had a fatal overdoses, on average, we're seeing 3 substances on board, and we have those data. There's also the syndromic surveillance data about, you know, when people are visiting emergency departments, what substances. And we have claims data But we also have, unfortunately, it lags a year or two, the National Survey of Drug and Alcohol, National Survey on Drug Use and Health, or NUSDA, which gives us not just the main data and a really good representative sample, but also how we compare to the rest of the nation and how we compare to prior years. So that the current year survey is happening as we speak. That's the people will be contacted, and you may start hearing from your constituents, is this a legitimate thing? It is, and they should participate if they're willing. So we'll have updated data. So that's the most kind of comprehensive look at the population as a whole within the state, not just kind of subsections based on claim or utilization, but it does lag. That's the drawback to that data. And certainly happy to share more detailed data on those sorts of questions as well. I just didn't bring it today. All right, to give you a sense of the demographic distributions, I put a few slides together here and have some updated, I have updated numbers as well, but we do see a reasonable demographic distribution based on race ethnicity. That's more, that is not necessarily reflective of the census of Maine. We actually see overrepresentation of people of color in the sample. Oh, sorry, I thought I had gender and sexual orientation, but I can show those graphs if people are interested. It's predominantly male, and about 2% of people who identify as LGBTQ in our sample. Getting into the campaign messaging, it's really important that we are both giving information, but also presenting a call to action. So not just giving people information about the risk, but also what they can do in response to that risk. But I'll pause in case Representative Madigan, your question is about the prior slide before I move on.
No, it's about this one. So
okay.
And then I'll add at the end.
Sounds good. I have some samples and upcoming slides about what the messaging looks like. But for this campaign in particular, these are the current messaging and calls to action. So one of the things we started to see at the beginning of the pandemic in the fatality data was a significant portion of people were alone when they unfortunately became victim to an overdose. So we really wanted to get messaging out there about that risk as well as alternatives to using alone. So you'll find that information on our website, as well as making sure we're getting that information out in a targeted way to people who are actively using substances. And because particularly with fentanyl being so fast acting and so lethal, we really want to make sure people are calling 911 as soon as possible when they're seeing signs of an overdose. So not just some of the other messaging that we've had about recognizing signs of an overdose, but also providing some reassurance around the Good Samaritan law to try to remove a barrier to people calling 911 when an overdose is suspected. So that's been a big portion of the campaign. As Gordon mentioned, getting out messaging on the real dangers of fentanyl, as well as the fact that it could be in any substance. People may not believe that they're using opiates, but could be exposed to fentanyl. And then coupling that with harm reduction strategies, offering messages of hope regarding recovery, and then connecting people to treatment resources. And then naloxone, the importance of having it, why it's so critical, and then when and how to get it. So Representative Madigan, your question was about this slide.
Yes, I'm wondering, as far as calls to action and messaging, and kind of this looks like a plan moving forward. Gordon referenced earlier what kept both him and Dr. Shaw up at night was the looming mental health crisis and substance use disorder crisis. In these slides, in this call to action, I see nothing about what we're doing for families who are shouldering that burden alone at this point. And in addition, I see nothing about what we're going to do about folks who have co-occurring disorders. Because if we accept that all substance use disorder comes from pain, nearly everyone's going to qualify for a co-occurring disorder?
Yeah, it's a great question. So let me skip ahead. We did make sure that we featured families as part of the real Mainers who are part of our messaging campaign. So we know that what can really inspire behavioral change, when you think about stigma reduction and what's going to resonate with people, it's important that they see faces and they get exposed to actual people, not just numbers, not just information. And so the campaign prominently features individuals who are in recovery from substances as well as affected family members. And to your point about the despair leading to substance use, that is a separate campaign, which is our Strengthen Me campaign, which is more about how to address distress, stressors, resilience, well-being, and how to connect people to resources. So we do have a lot of different messages in the options campaign. And then separately, we have a Strengthen Me campaign really geared toward helping people recognize the signs that they may be struggling and then how to connect to care. I mean, I'm happy to provide the committee with information about that. It's also been a very highly engaged campaign.
I would like more information about it, and I would like to know whether that information is getting to providers as well. Because I don't think it is. I think the system's failing people in multiple ways. And I say this not as someone who just sits on this committee, but whose sister died last Thursday morning at 5:25 a.m. from alcohol withdrawal. I am eternally grateful for the options program. Sybil Mazerall and Catherine Kutu were wonderful and connected me with someone who would finally do an intervention, which I had been begging every provider, every hospital who my sister was in to do, and they refused. They thought a taxi voucher was a discharge plan. And so last Wednesday, when I left the legislature, I called the admissions coordinator for the place my sister had agreed to go to, and we got off the phone, was helping her put on her shoes to go to the emergency room to start the detox process when the withdrawal seizure started, and I had to call 911. She went into cardiac arrest in my home. And I had to explain to my mother hours later what brain cell death meant. So no, I don't think many people are doing a good job of it, because if I couldn't get her the help, then I think many families are lost. And
Yeah, thank you.
For providing the services need to, when a family member asks for intervention services and asks for their support and help, it needs to happen.
I thank you for sharing that story. I'm terribly sorry for your loss. It is really important when we talk about who's affected in this crisis. It's not the substance use crisis. It's not just the individuals themselves. It's also all the people around them who are really struggling with how to support their loved one, how to connect them with help. Sometimes people are willing to accept it. Sometimes they're not. And being able to strike while the iron is hot when there is that moment of opportunity. And there are certainly elements to your story that I relate to as a family member myself. And everybody's situation is unique as well. But, you know, the campaign metrics only tell part of the story. We have engaged a really high number as a campaign metric, but we need to continue to make sure that people are aware of the resources and the importance of that assertive outreach. I think the layer here is another layer here that's really important is the rolling out of the service locator tool, because that's really one of the ways that we want to make sure, you know, families and providers and anyone who's struggling themselves gets connected to that real-time information, and also to the kind of screening components, because it can be hard, you know, as a family member and as a person who's struggling directly to figure out what is the care that I need? Not everybody necessarily has that background to know what's the right service for me or for my loved one, depending on what I'm struggling with. So, there's a lot happening, and there's a real urgency to continue to keep it moving forward. And thank you for sharing that.
You're welcome. I think the glaring problem for my family was, even though we knew what was needed, the inpatient facilities, both ICU and inpatient detox, med surge units, did not involve us.
Yeah, I really agree with Gordon's point earlier that it's one of our highest priorities to make sure that we increase that number of detox beds to, or the medically supervised withdrawal beds. And the ability to do that through the waiver is now available, and the funding is available. The real challenge that we're going to continue to struggle with and have to actively work toward is having the skilled workforce in order to staff those programs. But we're absolutely working on that.
What about long-term treatment beds, as far as either residential care or inpatient treatment? That's not just detox.
Yeah, I'll put that in the chat as well. Maybe most helpful, I could just put the one blog, because those also saw substantial rate increases under what we call the PNMI Appendix B, which includes things like extended stay programs, not just the medically supervised withdrawal program. So all of the residential levels of care saw a significant rate adjustment upward.
Have we increased the number of beds?
I'm sorry, I didn't catch
Have we
that.
increased the number of beds?
We have not increased the number of detox beds. We do have providers who are working on bringing more beds online. Unfortunately, what we're struggling with is them having difficulty staffing their current programs. So I think there's a willingness and there's funding availability. Where we're really struggling is trying to get enough staff. But I hope to have a more positive update. I really applaud the providers that we're working with. I mean, they know how hard it is to recruit for these positions based on workforce shortages, particularly when it comes to things like skilled nursing. But they're still trying, and they're still putting plans in place to open new facilities. And we're absolutely working with them on that, but it is taking longer than any of us would like.
Thank you.
Representative Stover, did you also have a question about this topic before I move along?
I did, but before I say anything, I just want to acknowledge my colleague, Representative Madigan, and say publicly how truly sorry I am. And with that being said, both based on what Dr. Shaw said this morning and both what you have said, Dr. Pollard and Gordon has said about concerns we all have, both on this committee and both from all of you as professionals, the COVID situation, the exacerbated stress that we're all under, the opiate epidemic that has been before COVID and continues even now in some ways much worse than it was 3 years ago. What, in addition to residential options and detox, and I can say from working at it, we are certainly on a daily basis in need of detox and long-term stay beds. What else do you see in the on the community-based care level? As you look at the data that you have and the information you have, what do you see in the plans for the current level of care and community-based care? And what about looking forward, whether that means case management, ACT teams, outpatient, intensive outpatient, what is the strategic thinking around a community-based system of care and ways to either enhance or raise it back up?
Yeah, I think it's really at two levels. It's the, well, maybe three. It's the rate reform process that we've got going on this year, which will include all the community-based services that you mentioned. And it's also developing those alternative kind of reimbursement models like the CCBHC. But then it's also, so that funds the service. But then I think we could spend all afternoon, and I'd be happy to actually, talking about all the different initiatives and work that's needed to get supplied with the workforce to carry out those services. That's been also a pre-COVID challenge. You know, we know that even before the pandemic, we saw a disproportionate number of psychiatric professionals reaching retirement age and some of the advanced practice credentials. And then real challenges with respect to pipeline for some of the frontline workers. And I think I feel really positively about the comprehensive nature of what we've got going on. We had we do a quarterly brief with the National Association of Mental Health Program Directors. And it's the number one concern of everybody who sits in my seat in every state. And we got a lot of positive feedback about how our package of strategies was really the most comprehensive in terms of immediate term, short term and long term, but also how we're trying to address credentialing flexibilities, and then also how do you pull more people into the field? Because just as we talk about stigma with respect to folks being reluctant to engage in treatment, that can also have an impact on choices people make even within healthcare. Do they go in the direction of behavioral health or psychiatric specialization? So we see that in med school, for example, you don't have as many folks going into that specialty area. So we have campaign investments for trying to draw more people into the field. And then the state as a whole for healthcare, how do we pull more healthcare professionals into Maine under the Live and Work in Maine marketing strategy or campaign strategy? So there are a lot of different fronts at which we need to hit the availability of community treatment, and that's really inclusive of the workforce components.
And can I just ask another question? Are those strategies addressing things like the long wait lists, and of course lack of staffing, which there's various reasons for that. One is pay, two is an aging workforce, and
yes.
3 around my area is there's no housing, there's no place to live. So no one's coming here to work and do home and community-based supports because there's no place to live. So I'm just wondering if some of the strategy is going to address some of these immediate things that are really dangling right in front of us. Those are the things I get calls about. I get calls from parents about their in-home providers. I get calls from people who do direct care, who are either going to leave if they don't get these increases or and go work at Dunkin' Donuts. So are there some immediate things beyond rate setting and continuing to look at this that will immediately impact some of this that we could get excited about?
If I understood your question, in terms of immediate term, we've got the worker bonus initiative. That is very soon. The process is already in place. Providers have already applied. That is rolling forward. And then there are for a lot of the behavioral health sections, the ramp payments that were through the legislature and the main care process, the cost of living adjustment upcoming. And then, next calendar year will be the implementation of new rates. But in terms of other immediate term pieces, what we really tried to do under the public health emergency is make it as flexible as possible for providers to move any available worker into where they need to have coverage for a service. As far as affordable housing, that's not an area I can speak to as much directly, but I do applaud the governor for appointing somebody in Gordon's shop specifically to focus on increasing the availability of affordable housing. And I think he gave a presentation. I shouldn't say think. I know he gave a presentation at a legislative lunch and learn that seemed promising in terms of investment in increasing the availability of housing stock. So I think there's reason for optimism there, but it's very hard to get through the immediate term.
Thank you.
Representative Lemley.
Thank you. I really appreciate this report, and I'm glad that as much is being done as we can do right now to help those people. However, my big concern, and I guess this question is to Gordon, I don't hear enough about what we're doing to eliminate the opioid problem. I hear more about how we're helping the people as much as we can who are already affected by this horrible disease. So how can we spend more money, and what can we do to get the opioid crisis lessened? That's my concern.
Oh, well, I'll start by, I read a couple of things in your question, Representative Emmerlin. One is the source. We brought law enforcement people together a couple of weeks ago, the U.S. Attorney, Commissioner Sawchuk, myself. We had all the federal partners, FBI, Homeland Security, alcohol, firearms, tobacco, state police, MDEA, DEA, everybody, police, representatives of the police departments. So much of it falls on them and the sheriffs, and they were there as well. And because we were addressing, there's actually at a time when there's probably more supply in Maine than there's ever been. And there's actually, and it's more lethal than ever. We've talked about that. There's actually fewer people doing interdiction. And that also is the result of workforce problems. As soon as local police departments can't fill their slots, then they bring their people back from the DEA task forces. So there's 14 vacancies in the DEA task forces. Those are what we really rely upon to do arrests, seizures, investigations. So the governor and I absolutely believe that the supply side does need to be addressed, as well as the demand side. In the long run, there's probably not a lot we can do on the supply side because it's about international drug cartels and they can get it here. We could triple the money and the drugs would still get here. But we can't, we don't want to be putting in a billboard down at Kittery, say, bring it in, make it as dangerous as possible. We have to do what we can. And that's what we were working with law enforcement. So they are important partners to us. And we do need to affect the supply side to the extent that we can. In the long run, you're also talking about primary prevention, that we have to go way upstream to the maternal, the mom program, substance affected infants, adverse childhood events, resilience, trauma. There's a reason that people use drugs. There's a little bit of genetics in there, but most people are reacting to horrible things that have happened to them. So that's why I say our strategic plan, and it's updated continually, but it is still focused on all 4 pillars: prevention, treatment, which you just talked about, and no, we don't have enough treatment. And by today's presentation, we don't mean to suggest that all the things that we have accomplished in 2021 that we have fixed the problem. Clearly, we haven't. We need more treatment, and it is the highest priority: residential treatment, detox, adolescent treatment. But we also do harm reduction because we do want to keep people alive and give them the hope of a better future. And we want to support people in recovery by helping them with recovery coaching, recovery centers, and housing is incredibly important. So this person that Dr. Paul had mentioned, Greg Payne, is in our office, and there are a lot of initiatives and a lot of money being put into housing, and also being put into healthcare workforce. Some of that's ARPA money, and so I'm optimistic that 2022 will be better, partly because we will have more resources, some from the Attorney General's settlements, a lot from the federal government, a lot from the ARPA funds from the counties and cities. So, you know, we have the plans, and I don't like to ask people to be patient, but I do believe myself that as we put the pandemic in some way, shape or form behind us, we will be able to devote more effort and attention to this issue. You know, managing the epidemic within the pandemic, if it wasn't for the pandemic, this issue that we're talking about today, that you all care so deeply about, would be the only thing that people talked about. We would be in the front pages every day. It would be seen as a huge the public health crisis of our time. But COVID does crowd out a lot of things. And while I want to believe that government can handle two public health crises at the same time, it is a heck of a challenge. So that's my a lawyer's long-winded answer to your question, Representative. But all these things have to work. The prevention work and affecting the supply side as well. And that's our job, to get resources on the ground and making sure that all these areas are positively affected.
Okay, well, thank you for that. I appreciate it.
Well,
See, there are more questions. I'm happy to answer them or cover a little bit of the campaign information either way.
Representative Perry, did you want to ask a question related to the stuff that's on the screen?
I guess my question is really related to some of what Gordon had said. In terms of looking at the approach with recovery centers and how you feel these are working, and looking at what funding does go to the recovery centers out of this work that we're doing. I have one other question, but we'll leave it at that.
I think the recovery centers are important. As you know, you have 2 in Washington County. We have now 18, and we have a plan that eventually we'll have a pool of money, and I think all the centers will be able to apply for whatever we've been able to put in that pot. They're really homegrown things. They're places that people can go to. They don't provide treatment, but they refer people to treatment. We do recovery coaching. We do support group meetings, and you can center a lot of activities there. And they do help break down stigma. And so we intend to continue them. I have in the new budget, in the prevention treatment plan, I have money for 4 more, that 2 which are virtually open in Augusta and Sanford, and then likely Rockland and whichever other county. There was a piece of legislation that was considered and passed, I think, without money, that where we obligated ourselves to give priority to any county that does not have a state-supported recovery center. And that would include today Somerset, Oxford, Piscataquis, and Waldo is in there too. And so I think they're an important place to center a lot of our activities, and I'm absolutely committed to continuing to fund them at some level, with a plan to have them all supported in an equitable fashion by 2023, probably.
I would just add to that, you know, when I did direct service work early in my career, I was very struck by working with, when I was working with people who were trying to engage in treatment around substance use, that woman I was working with making the comment, you know, what do people do when they get sober? You know, that your whole social center is circled around substance use. When you're using substances, that's your social network. Those are your activities. And it made an impression on me about the importance of, it's not enough to, you know, work on treatment of not using substances. You have to help people work to build a support network and a whole life outside of substances.
Representative Meyer?
Thank you, Mr. Chair. My question goes to probably to Gordon, with whom I've had somewhat of a dialogue the last couple of months about fentanyl test strips. And I haven't seen a lot in the presentation about FTS, but I do have to wonder, since the majority of our overdose deaths are fentanyl related, where are we at since October 18th, when we've been able to distribute test strips with that initiative? It seems it is a simple, effective, inexpensive, evidence-based method of averting overdose. And I wonder how we are getting those strips out there.
We're absolutely doing that through our naloxone distribution initiative. I mean, we built that system over 2 years of tier 1 distributors, tier 2 distributors. So we're getting them right now at no cost at 2,500 strips at a time through a grant in northern New England that comes out of Vermont, federal money behind it. And so, but we absolutely now will be distributing it just as we're distributing naloxone. Now, again, some people may not take it, but we plan to have it available in a kit that's available to every person that's released from a county jail. So we are absolutely committed to it. As you say, it's only been legal in the state for like 2 to 3 months, but we are getting them in packets of 2,500, and we're distributing them through the network to anybody that needs them. And there's not a lot of clinical literature, but there's enough to try it at least, that suggests that some people, if they do use a strip and find that there's fentanyl in the product, they will use differently. They will use less of it. And if it keeps a handful of people alive that otherwise would die, it's worth it. So we plan to distribute and are distributing on a widespread basis.
Thank you.
I'd also like to point out to the committee, remind them that when Dr. Sorg is here, we'll also be hearing from the Maine DEA next Tuesday. So I'll ask our analysts to pass along to Dr. Sorg. The question was asked about bringing types of overdose data with her when she comes. Thank you.
These are great questions. I just want to acknowledge the work of our marketing partner on this mishmash. This campaign has been, by many indicators, a quite successful campaign in terms of the engagement and around the materials. And 52 million impressions is a pretty significant number for a public health campaign in a state of our size. And I have to say, it's the only campaign in my career so far where we've had a Super Bowl ad, and that feels like something to note. So really good engagement. Not only are people seeing the materials, but they are engaging them, following up on website visits. And then, as we can see through the behavior that people engage in once they come to our site, using it to do things like access the contact information for their local options liaison. And to go back to fentanyl, we do have, we really stepped up the focus on fentanyl in the campaign. So there are different kinds of marketing and, there are different kinds of messaging associated with fentanyl. And one of the great things about social media in the context of a campaign is you can really use it to see what resonates with people. So the content that you can test out on social media and see what people are engaging with, what they're liking, what they're sharing, can give you a sense of which messaging might be more effective, and then you can amp up that messaging. So only since October 2021, and we've seen over 156,000 impressions on the fentanyl-focused messaging. And this gives you just a brief description of the different messages in the fentanyl-focused messaging. So really trying to impress upon people that it could be in any substance, because people are not aware of that. They may think they're using stimulants. They may think that they're not using opiates, but they absolutely could be. So That's a big focus of the campaign, of the messaging. And this is to give you a sense of what the look and feel of the ads are. There are different types of aesthetics and messages, since we want to try out a number of different approaches to see what people would react to, what kinds of messages they might respond to. And then it is, of course, also alongside the DEA messaging around fentanyl as well that's getting out there. We're trying to boost the signals of other campaigns along with putting out our own material. So that's that. And this was just a summary of the information Gordon provided to you via the handout. So we don't need to go over that again, but it gives you a sense of the dollar amounts and the initiatives funded last year. And I think that's it. So I will stop screen sharing so we can see each other and see if there are other questions.
Yes, Representative Zager.
Thank you, Mr. Chair. And I really appreciate this presentation, Dr. Pollard and Gordon. There was a mention at the very beginning that Gordon said about the money that is coming into our state from the opioid producers, and there was the memo and report from last July. My question is, at the very end of that, it said that that legislation would expire, that requirement would expire September 1st, 2023, I think. And so my question is there any plan that or legislative vehicle that you're aware of that would extend that in time to meet that?
Yeah, I'm glad you asked that question. That's very discerning of you to see that. I believe, and Anna and Sam can double check me on this, but the part that expires is only the part about the reporting by the Board of Pharmacy as to whether the law has impacted people's ability in Maine to get opioids, not the assessment. Because I did see that reference many, many months ago, and I said, holy cow. Yeah. So I virtually am certain that that's the case. So, and I don't know that that the Board of Pharmacy will really be in a position to tell us a lot about access to opioids. I mean, the fact that there's well over 20 mostly generic manufacturers of opioids selling their products in Maine, I really don't think it's going to have a serious impact upon people's ability when they, particularly for short-term acute pain. Opioids will always have a role in acute pain, and fentanyl will always have a role in anesthesia. I mean, you've got at least 2 doctors on the panel. I don't need to be telling you those things, but I do want to say, really addressing Senator Claxton, I had given this an hour, and I do have kind of a hard stop at 2:30. There's a national group through the Governors Association that is very impressed with what we're doing with the syringe exchanges and them working with the liaisons, and how we're working throughout with the governor's office and the CDC, which regulates the syringe exchanges, to deliver that really important public health benefit. When you're in my position, you think about, okay, I really need to reach people who are still using drugs in Maine. It's not like they advertise themselves, right? So where would I go first? Well, where do I know? Well, I've got 5,400 clients of the syringe exchanges, anonymous, but terrific staffs at those 18 facilities. 5 of them are mobile and not yet open, but still, we've been able to get one up into Worcester County. We've been able to get into rural areas without some pushback that you might well expect. There's been some pushback, but it's really about keeping people alive and not spreading infectious disease of other types, HIV, hepatitis C, tuberculosis. So anyway, that's the long way of telling you that I got 9 minutes and then I really have to leave, and I apologize for that.
Let's make sure that anybody has a chance to ask questions of Gordon before he disappears. We'll save some more time for questions of Dr. Pollard, and it would be good to hear too from Geraldine Betts. Any questions for Gordon? Nope. So thank you, Gordon, for being here. Thank you for bringing your information, and thank you for your ongoing work.
Great seeing you all. Thank you. Sorry to leave. Jessica, good luck. Good luck.
I mean, I was turning down another meeting to stick around a little while longer, but
So Senator Moore, you had your hand up. Did you want to ask a question of someone? When you're unmuted?
Yeah, there we go.
Yeah.
I did, and I appreciate that. I know that this is a very dynamic list of initiatives that, and we've been talking totally about the substance use disorder, and there was a little bit about mental health that was in there. Do we have similar initiatives addressing the mental health crisis that we are facing in Maine?
yeah, I'm happy to either now or at another time talk about the all of the work going in around mental health. You know, when I say behavioral health, when I was talking about the workforce initiatives and the main care reforms, that includes mental health as well. And you know, I think you'll hear from me next week too, talking a little bit about some of the flexibilities we'd like to see for assertive community treatment for the LD 1848. But there are a number of initiatives ranging from some of the rate reforms and changes to the crisis system to what we're doing around trying to increase the availability of workforce to deliver the services. So absolutely. And you know, on the public facing campaign side, that would be the Strengthen Me initiative. And I'd be happy to give you some data about how that's been going as well.
I think that would be very good because we're hearing so much and they're almost going hand in hand, and the pandemic has made it worse. And so I think we definitely, it would be good to have some more information on what we're doing in the mental health field as well.
Absolutely.
Representative Perry, you had a question?
I had a question, but I had a comment. That would be wonderful if Dr. Pollard could return with actually a report on mental health in Maine and what we're doing specifically. I think that is something would be good to get a robust picture of. But the question I had actually related to the campaign that you were doing for the Good Samaritan law on this piece. First of all, whether people believe that that's true, but I guess the other piece of it is, are providers aware of this? Are people who are in the position to be able to really do something about it aware of it so that it doesn't become a problem once it's instituted?
I want to make sure I understood your question. Or it sounds like maybe you're asking if people trust in the Good Samaritan law, and also are the people who are in a position to communicate that information to the people who might most need it. So providers communicating to people who are using substances, are those folks aware of the Good Samaritan law? Is that the question?
Yes, and also those people who would arrive at the site.
Gotcha. Yeah. Hard to say with any kind of certainty in terms of there's anecdotal information, but we haven't, that I'm aware of, there isn't a kind of more systematic look at the trust in the law. We've done other kinds of surveys related to things like knowledge of naloxone and likelihood to make use of it, but I don't know that we have reliable information on how much people know about it, how much they trust in it. We certainly hear anecdotes that people do have wariness, and so that's one of the reasons why that's a focus of the campaign. We've had conversations about the limits of the law, and certainly I think there's a difference between what the response on scene might be versus any kind of resulting actual kind of prosecution based on the protection under the law. But certainly people would still be concerned about the immediate interaction. So I wish I had more more than anecdotal information, but I don't. But we are, to your point, we're also trying to get that directly into the hands of people who are using substances. So, you know, we rely pretty heavily on a lot of our partners in the naloxone distribution, the syringe services programs, and then trying to make sure that absolutely treatment providers as well in our recovery community centers, we try to get them a lot of our materials to help us distribute it, but also for their own awareness too.
So not seeing any other questions, I want to at least give Geraldine Betts the opportunity to share any input she think would be helpful to the committee from the Board of Pharmacy. That's an invitation, not a stipulation. So if you weren't prepared to jump in, we'd understand. Welcome.
Thank you. Good afternoon, Senator Claxton, Representative Meyer. Thank you for today's invitation. I was not prepared necessarily to give a speech or deliver information, but certainly would be happy to answer any questions. Our role has been to be collecting the fee assessments based on what was required of us to do. And I do appreciate Mr. Smith's accolades for our office. And I have to say, I think I would then transfer that to my staff, who has done an awesome job about communications and trying to collect the funds for this most important matter. So I'm prepared to answer any questions, at least try to answer questions that you have. We are ongoingly collecting fees. We have just finished the second the second full renewal from when this law first took effect. So we've gotten a little better about it. And as Gordon pointed out, we are trying to provide, obtain information from the ARCOS reports to determine if there are any manufacturers out there that should be registering for the $55,000 fee assessment as a producer of opioids, and to determine any that would have or meet the 2 million mark that would put them at the level of the $250,000. So we are working actively on that right now. Actually had a meeting yesterday with HHS group to try to obtain a report that's readable and user-friendly for us. And we have prepared a communication that we're hoping to get out in the very near future to make sure that manufacturers are actually providing the information we need to pay for these funds that are being required.
Thank you for that. Are there any questions about that process and the funds collecting? Seems like those funds have played an important role in a bridge between getting settlement money into the state and provided the access to some resources we wouldn't otherwise have had. So thank you for making that happen and work.
You're very welcome. It certainly has been a learning and process as we go with this one.
Very good. So Senator Moore, did you have a question? Your hand was up a bit ago.
I did. And I was going back to with Dr. Pollard on the launch of the 988 program. I haven't seen any marketing on that. Is that something that is in the plans, or what's the progress, I guess, on it?
Yeah, so marketing is part of the plan. So we've been meeting as a coalition of representative stakeholders to make sure that we have all the logistics worked out for how the process will work and trying to increase capacity. Right now, the calls that come to Maine from the National Lifeline are a pretty small portion of the overall calls handled by the Maine Crisis Line. But we do expect that a 3-digit number could potentially divert more people away from other lines and behaviors and to the Maine Crisis Line. So marketing is part of the plan. The National Suicide Prevention Lifeline and their vendor Vibrant are developing a lot of the materials. I think there's been a little bit of hesitancy about marketing too soon because the number isn't live yet.
Okay.
But once it becomes live in July, that is a part of the plan to make sure people know about it, and also that they know it rings locally, so that, you know, similar to 911, it's a national 3-digit number, but when you call it, you get your local PSAP. So we'll be doing some marketing about that. And we have a small planning grant that we received to do the lead up work. And then similarly, SAMHSA put out some small formula grants to states around the increased capacity necessary to support the 988 rollout. So there's a lot going on. Your colleague, Representative Morales, and Representative Supika are members of our planning coalition. We've met, oh gosh, handful of times at this point, providers, different stakeholders. We're in the process of doing some focus group and kind of qualitative work around service users, so people who use the crisis system and people who don't use the crisis system, to try to get a better sense of what might be hesitations, what we might need to focus our marketing messaging around. But we're pretty excited about it because at the end of the day, a 3-digit number is just going to be much easier for people.
Right. Thank you.
So that sounds like that's why you've not heard about it, because it's not been rolled out yet.
Yeah.
I mistakenly, I think I wrote down July 2021. That's my problem. I was thinking it had already been launched, but it's 22, so that makes sense.
I think
Yeah, and it's not even on the 1st. It's a weird, like July 12th or some random date. I'm not sure why, but
who knows? Probably somebody's birthday or something. Who knows?
Are there any other questions from the committee for Dr. Pollard? I'm not seeing any. So we'll thank you very much for bringing this to us and sharing what we hope will be plans for a very successful year, and that the circumstances surrounding the year will get a little bit more manageable. But obviously lots of thought and energy has gone into it. So thank you very much for being here. Thank you for making yourself available, and for the work that is nowhere near done. So
yes. Thank you for having me.
So to our analysts, the 2 specifics I heard was some interest in having Dr. Pollard back to talk about a comparable presentation on what's going on around mental health crisis. And so we can leave that to you all. And I had mentioned earlier the request for additional information, or to remind Dr. Sorg to bring that with her when she comes. So anything else for analysts that has come up for folks that we'd like to commission them to or request them to do? I'm not seeing anything. As I look at the calendar, it looks like we'll be getting together again on Tuesday. And I can't remember what time that is, but you don't trust me until I look it up. It says
It's
10 o'clock.
10 o'clock.
10 o'clock on the 18th. Okay.
I think you'll be getting a weekly later today.
Okay. Very good.
I just want to mention, Representative Zager, that Gordon is correct, that it's only the reporting that is sunsetted.
Thank you very much. That's reassuring. Appreciate it, Anna.
And I don't think we should leave without, again, acknowledging where Colleen is in her struggles to get her feet under her in a very tough circumstance. So we appreciate you sharing your story. I can't imagine how painful that is to do that, but it makes a big impression and it helps improve things. So thank you, and my personal and committee condolences.
Thank you. It didn't need to happen.
Okay, folks. So time to adjourn. I'll entertain a motion to adjourn, and we can second.
Second.
And all those in favor, show your palm, and we will see everybody on Tuesday morning. Thank you.
Have a great weekend, everyone.